Bizim ilk çıxışçını təqdim eləmək üçün Seymur doktor bu deyim.
Birinci çıxışımız, our first presentation, Carlos Mestres, acute aortic dissection, current knowledge, evidence and practice.
Good morning, ladies and gentlemen. I'd like to thank Dr. Kamran Musayev and the organizing committee of the Baku Heart Days for inviting me again to participate in this very important academic activity. I'd like to discuss, according to program, on acute aortic dissection and what we know today. I have no conflict of interest and welcome from Zurich in Switzerland, from the University Hospital. This is what we are going to discuss quickly today because of time constraints, and I hope that we can have an idea of the current status of something which is very important, like aortic dissection in our specialty. Acute type A dissection, we know, is a highly lethal disease which might be in incidence, and surgery is believed to extend life and save lives. Optimal surgical management remains still unclear. According to this seminal paper by Olson, published a few years ago, we've seen an increase in the incidence of aortic aneurysm and dissections in the Western world in the past 15 years. So the figures are very clear, as you can see in this slide. The definition is also well known. This is a rupture of the medial layer of the aorta, which results in the separation of two layers with the subsequent formation of a true and false lumen, and 70% present in the ascending aorta or the aortic arch. With regards to classification, we have different issues in terms of how to categorize that. In terms of presentation, the temporal classification, well known and contemplated in guidelines, is acute, subacute, and chronic. On the other hand, the IRA, the International Registry for Aortic Dissection, proposed a classification which tries to interact time, location, and tear, and treatment with survival. This is why they contemplate hyperacute, acute, subacute, and chronic dissection. Furthermore, the classical anatomic classification by the Baku and Stanford University is known for 60 years. So Stanford University contemplates type A and type B according to the location of the tear. And the Baku considers three types, 1 to 3, according, again, to the location of the tear for identification. This is probably a nice scheme to summarize what the aortic dissection is. On the other hand, the term non-A, non-B aortic dissection was proposed in recent years as the clinical presentation, treatment, and results in this specific scenario are different as those reported for types A and B. And that comes from the old definition from Fonseca and Passage. Finally, in terms of what we know and use today, very often the functional classification or the PEN classification that was initially published by Augustides and colleagues from the Penn State University in 2009 introduced the concept of vessel malperfusion. And then we have class A with no ischemia, class B, malperfusion of a vessel leading to organic ischemia, class C when there is cardiocirculatory collapse, and a combination of localized and generalized ischemia is considered class B and C. Very recently, Sievers and colleagues in Germany, they have issued the integrative anatomical and functional classification, the TEM classification, which at the end integrates all that we know about anatomy, function, and physiology. And this is the TEM classification that was released very recently, so early last year. What do we know about surgery? Whether we like it or not, let me say that the optimal surgical management remains unclear. Believe it or not, this is what we see even today. Although we know that the primary aim of surgery for dissection is to prevent intrapericardial rupture. About a decade ago, we were able to organize this review on the evidence, lack of evidence, controversy, and debate in the provision and performance of surgery for acute type A dissection, because 10 years ago, and even today, there are still some areas for discussion. And that was a good summary at the moment. We were going to go through that. We know, or we presume we know, that surgery for acute dissection has shown to decrease mortality in the first couple of days after the primary event. And surgery, on the other hand, increases survival in comparison with the conservative management. This is very clear in the literature. For discussion, we have a number of topics. We know that, on the other hand, many dissection patients die before antemortem diagnosis or treatment. And the untreated mortality for type A dissection usually is about 1 to 2% after symptoms over the past 24 hours. And about 90% of them, they are died within 30 days. On the other hand, we know that surgery is still in 2021 a higher risk situation. And mortality and neurological complications altogether may comprise between 15 and 30% according to the series. And this is despite an increased understanding of the disease and improved anesthetic surgical techniques and organ protection and advances in postoperative care. On the other hand, we know that there are no randomized studies of medical versus surgical management. They have never been performed. Evidence is that surgery converts a 90% mortality risk to at least a 70% survival chance. And this is why, because of this magnitude of the effect, acute dissection is a very accepted indication for surgery, because we also know that no more than 2 patients are needed to be treated to gain a survival benefit. And I think this is very important. On the other hand, the survival advantage of surgery continues in the long term, and the survival curves, they continue to diverge versus medical management. We still have a number of controversies. I think this is important to remember. First of all, if we are diagnosing and treating all patients, we know that today we have phenomenal CTs, TEE, transesophageal echocardiography is a tremendous technique to diagnose and work on descending aorta. We have biomarkers like the dimer, but even though today, with all these advancements, a number of patients, they arrive late because there is a late diagnosis. On the other hand, for controversy discussions, we have the selection of patients for surgery. Should all patients with dissection be operative candidates? That's been addressed in the literature, and then we have patients that may come under arrest, under cardiopulmonary resuscitation, patients that are comatose, and the question is if this is a futile effort to save these patients. Moreover, in the Western world, the discussion about the repairing octogenarians and when and where should surgery be performed. I think these are important questions even today. We know, and this is a summary of all the independent preoperative risk factors for mortality with acute type A dissection. Every single statistic published so far understands that the odds ratio for mortality are really high when there is history of prior aortic valve replacement, when there is a shock or tamponade, and of course when there is preoperative pericardial tamponade as well. The issue of malperfusion, I think this is an important one because malperfusion phenomena have an incidence between 15 and 30% and might result, of course, in organ damage at any level. And here we see the survival curves of patients in the left-hand side with any sort of malperfusion, in the middle with cardiac malperfusion, and in the right-hand side, cerebral malperfusion. So it is very clear that malperfusion syndrome plays a fundamental role in early and late outcomes as well in the field of aortic dissection. We have more issues to discuss. One, in terms of surgical topics, the arterial side cannulation. In the past 20 years, subclavian cannulation has gained predominance and currently seems to be one of the most popular approaches for arterial return. However, the question could be if superiority of this approach has been confirmed. I think we all practice subclavian cannulation, but on the other hand, there is people who routinely cannulate carotid arteries. And then carotid artery cannulation is also well practiced all over, like femoral cannulation as before, direct or transapical. So I think this is still a matter of discussion because some others may think in a different way, may cannulate different way. Second, to clamp or not to clamp the aorta at a given phase of the operation. to glue or not to glue the aorta. There have been a number of reports on embolization, and on the other hand, of course, sinus retaining or non-sinus retaining operations with valve sparing experiences. There are recent reports that show excellent results with valve sparing operations when the aortic valve is not involved in acute type A dissection. Other surgical topics today are what for us does a patent distal false lumen mean? Do we need to do something? We need to change strategies in the acute operation or not? Should we always extend repairs into the arch or distally? Should we perform hybrid replacements all the time? What is true is that we need to protect the brain and the organs, but even in cerebral protection, there is still some controversy with regards if we have to proceed with antegrade, retrograde, combined, or if hypothermic circulatory arrest is only enough. These are questions even today for discussion. Then what we have done, what we did in the past. With regards distal extension, always yes or not, and then the frozen elephant trunk, which is also popular today, yes or not. I think that's an old story now, but when we look back, and this is a very good example of teamwork. A few years ago, we published this kind of status and recommendations for the use of the frozen elephant trunk in type A dissection, and that was a position paper by the vascular domain of the European Association of Cardiothoracic Surgery. So there was a lot of work on that. The summary of the whole thing, even when we understand and analyze the experiences published so far, is that the frozen elephant trunk definitely has broadened the armamentarium of surgeons and simplified the treatment in a specific, very complex thoracic pathology. However, and that's been, of course, criticized, a trade-off of regarding a slightly higher rate of spinal cord ischemia seems to be a serious problem, and then we might need some further research to clarify the mechanisms of symptomatic spinal cord injury and reduce its incidence. This is why the companies in the biomedical sector, they have modified this prosthesis, this hybrid prosthesis. The question of the arch always yes or not, again, it raised a number of questions and doubts. Again, this is what we did. Less than a couple of years ago, we published these recommendations for the treatment of thoracic aortic pathologies and, of course, acute type A dissection involving the aortic arch. And the good thing that was an expert consensus document of the two major societies in Europe, the European Association for Cardiothoracic Surgery and the European Society of Vascular Surgery. We came across a number of recommendations on the left-hand side. This is extremely clear. This is transparent that specific aortic pathologies involving the arch, like dissection, need, whenever possible, an aortic team, centralized care, specialized centers, all these discussions, but with a strong level of evidence. And some of these recommendations, they are still today under discussion. But the problem, the goal is that the aortic dissection, acute type A aortic dissection, must be definitely be treated in any way on an urgent basis. Specific subgroups of patients, like for instance, those operating teams that get patients in the operating room under cardiopulmonary resuscitation, or that patients have been resuscitated before. There is not much experience out there, but we have two very recent contributions, one from our team, another one from Japan. And at the end, important is to remember that in those patients, there was a survival rate of about 40%, not too many. We had in this publication up to last year, 26 patients. This Japanese experience with more or less the same experience, between 4 and 6% of those patients. And finally, the conclusions were that duration of CPR beyond 15 minutes may be a contraindication for operation for type A repair. And the colleagues in Japan stated that we should reconsider surgery in patients who cannot achieve return of spontaneous circulation after pericardiotomy. So I think this is a very complex subgroup of patients, but we have learned a number of things. There are, of course, special situations. One are octogenarians. Second is the association with coronary bypass in dissection. Our group is going to publish soon in the Seminars of Thoracic and Cardiovascular Surgery an article on that. And then we found that the mortality definitely is much higher when patients require coronary artery bypass. We are also working on dissections in patients who receive NOAC therapy, the novel anticoagulation, that it's true that increases bleeding and mortality in comparison with patients that they don't get NOACs. And there are, of course, more topics for discussion. In octogenarians, and this is the last part of this discussion, we have now a number of contributions. This very recent from last year from Taiwan, in a series of 4,000 patients from the National Registry. The conclusion was very clear, is that octogenarians receiving aortic dissection operation actually get much worse late outcomes than those who are non-octogenarians. And these are the curves for survivals and also for reoperations for aortic problems. So it is very clear that the results in octogenarians, they are different than in non-octogenarians as well. And this interesting contribution from Japan also from a few years ago raised the question of if the surgical intervention for acute type A dissection should be performed in octogenarians. And there were also very interesting conclusions. Emergency surgery for octogenarians showed apparently acceptable in-hospital mortality. However, because of neurological damage and development of dementia, or those patients who became bedridden, it was very important to have a consensus with the relatives of those patients because of those suboptimal results. These were the results in terms of in-hospital outcome. You could see that especially patients who were bedridden, and of course that led to family claims. And in terms of quality of life, in group 1, those patients who were operated beyond 80 years of age, the dementia and depression with bedridden patients and non-recoverable patients was extremely high as well. And that prompted this discussion, this editorial by Dr. Martin McNeely, the ethics editor from the American Association for Thoracic Surgery. And that was a magnificent editorial that I would recommend you to read even 10 years later. So we did not expect dementia diapers, and that was the reflections on that Japanese experience as well. Finally, and although it does not strictly apply to our aortic dissections, let me go quickly through wrapping of the aorta, which is becoming in the past 10-15 years acceptably popular in specific circumstances, not only for dissections, mostly for aneurysms at different ages. And that was described many years ago by Robiczek. But this recent report from Germany, from Dr. Schäfer's group, showed that for those patients in whom wrapping of the aorta is performed for any reason, after some time, actually the structure of the aorta disappears. So the wrapping of the aorta induces tremendous pathological changes in the ascending aorta. And that was discovered many years ago. This is a brief contribution for 20 years ago from Neri and his colleagues in Italy. And that was the question. There was not only a mechanical matter, there was histological modifications of the aorta underlying external banding because of wall degeneration, which was induced by the interruption of the nutritional vasovasorum of the media, enhancing a chronic inflammatory injury by body reaction to the wrap and so on, inducting at the end atrophy and sclerosis of the aorta, facilitating the development of false aneurysm, different pathologies. And this very recent article from Korea a couple of months ago on the long-term fate of those patients with wrapping, it was very clear that after surgery of any surgery of ascending aorta, wrapping, the proximal arch diameter significantly increased over time. And there was, of course, a much higher incidence of aortic dissection in the wrapping group at all types, arch dissection, in this case, all were reoperated, or a type B dissection in comparison with the replacement group. And this is why we need to probably discuss what to do. This is a very recent case from one of my colleagues, and this patient, it was an 87-year-old a female patient with a preoperative diagnosis of Stanford A, the Baku 2, and Penn A aortic dissection, which was a marginal patient. At the end, the decision was made to operate on the patient, and postoperative, just 1 week after the operation, we could see thrombosis below the wrap and a massive compression of the aortic lumen, as you could see here from the aortic root, and in this case, a new distal dissection. So that, of course, may raise a number of questions with regards to the use of wrapping specifically in aortic dissection. The future is around the corner, and although this patient that you could see here, the first supposed to be endoventral procedure for treatment of descending aorta and aortic valve, was not in a patient with aortic dissection that was published about a year ago by these colleagues from Brazil, that could give us an insight of what is going on. And it's clear from this recently published review just a few weeks ago that the catheter-based treatment of the dissected ascending aorta, according to the systematic review, is probably in the horizon. So far, about 100 patients have been reported after aortic dissection catheter-based therapy, with a 10% mortality, with a 2% bailout conversion to surgery, with 3 to 5% stroke in hospital in a very early follow-up, with an 8% of reoperation in a short period of time, and also with endoleaks and reintervention. So this is around the corner, and probably in the future that will change. To conclude, I would like to tell you that type A aortic dissection continues to be challenging. Some management aspects are still controversial. The optimal surgical therapy is still to be defined. Specific situations still need cumulative evidence, and the future may eventually contemplate endovascular therapy in selected cases. And with that, I would like to thank you very much for your attention, and I'm, of course, available for any possible question. Thank you very much.
Tamam, buyurun. Bu değerli çıxışı üçün Carlos Metes'e çok teşekkür edirik. Thank you, Dr. Carlos Metes. Bir sualınız, Semir Doktor, buyurun.
I want to ask one question from Carlos Metes. This one of risk factors, fat and body weight. How much in your practice? How much kilogram body weight? How much was very high body weight patient?
Için Carlos Metes'e teşekkür edirik. Thank you, Dr. Carlos Metes.
Hello.
Okay. Oldu. İndi isə sıradakı çıxışçımızla əlaqədar demək, Ozaki mi yoxsa Ross mu, hansı pediatri praktikdə daha yaxşıdır? Bu mövzuda çıxışçımız Seçenov Universitetinin kardioxirurq konsultanı Əlişir İsmailbəyov çıxış eləyəcək. Buyurun Əlişir bəy. Dr. Əlişir, we are waiting to hear your speak.
Good day, dear colleagues. Do you hear me?
İndi isə sıradakı okay. Dr. Carlos, we will ask you after all of this speak. We will discuss all of them. Can you switch off all YouTube, all? Okay.
Do you hear me, dear colleagues?
Okay. Yeah. We are hearing you.
Yeah, we hear you.
Okay. Do you see my screen? My presentation?
Dr. Yes, we are seeing. We will ask you after all of this speak.
Thank you.
We will discuss all of them.
Thank you. Sorry, I didn't.
Switch off all YouTube, all.
Thank you. I didn't hear well. There was a lot of interference. This is why I did not understand well what you said. Okay. Okay. Thank you.
Thank you.
Let me to begin.
Okay, you can start.
Okay. Do you see my presentation?
Yes.
Oh, okay.
You can continue, please. We are waiting you.
Okay. Good day, dear colleague. My chief, Professor Roman Komarov, cannot present our research due good reasons. He urgent left Moscow. So we gonna to present you pediatric aortic valve neocaspidization with glutaraldehyde treated autologous pericardium, the first Russian multi-center report from 5 cardiac surgeon centers in Russia. So there are several approaches for pediatric AV surgery, like classic replacement using biological or mechanical prosthesis, AV commissurotomy, Ross procedure, EVNEO procedure, aortic valve neocaspidization using glutaraldehyde treated pericardium, aortic valve repair using augmentation technique, and balloon aortic valvuloplasty. Classic replacement has high needing of warfarin during the years of physical activity of the child. Problem of prosthesis patient mismatch, penis formation during follow-up, high risk of mitral valve disease during follow-up, like a predictor of late mortality, risk of thromboembolic events, risk of ascending aorta dilatation, prosthesis high gradients possibility compared to other procedures, and 10 years surviving after classic replacement in pediatric cohort is 81%, 10 years freedom from reoperation, 78%. AV commissurotomy is a palliative procedure, has a lifetime risk of reoperation, and allow 10 years freedom from AV reintervention, and allow 20 years freedom from reintervention. And the freedom from aortic valve replacement during follow-up is very low, is 53%. So balloon aortic valvuloplasty is a palliative procedure too, and has a lifetime risk of reoperation, and allow positions of 10 years freedom from AV reintervention and 20 years freedom from aortic valve reintervention is very low, 23%. So freedom from AV replacement during follow-up is 32%. Aortic valve repair techniques using commissurotomy with aortic leaflet augmentation using pericardial patches. This is an acceptable bridge for aortic valve replacement in future, and has satisfied freedom from reoperation, H1 and 79% for 5, 10, and 15 years freedom from reoperation. But this technique has a high risk of AV regurgitation and stenosis in future. So the Ross procedure became a golden standard in pediatric AV surgery, especially in newborn's aortic valve surgery. So in these conditions, we don't need for anticoagulants. We have excellent post-operative aortic valve hemodynamics, similar with native aortic valve. But it's very difficult for surgeons with low experience because there is a technical complexity like two valves interventions, prolongations of bypass and cross-clamp duration. Risk of right ventricle output tract conduit dysfunction with high need for reoperation. And there are doubts to use in patients with severe aortic root dilatation. So, in current publications, we have allow data for left outflow tract reintervention is 59%, and allow 15 years freedom from right ventricle outflow tract reintervention is 53%. Aortic valve neocuspidization procedure, we know it like Ozaki procedure or Durand procedure. This procedure, no need for using anticoagulants. We have good postoperative aortic valve hemodynamics. We have no problems with prothesis patient mismatch. So this procedure is satisfied for small aortic annulus. Preservation of the aortic root anatomy dynamic, and the long-term period in the pediatric population is poorly studied. So in current literature, we didn't find many publications for Ozaki versus Ross procedure data. We have only 4 presentations with medium or low patients. The study purpose, we present the first Russian multi-center comparative study of various techniques in pediatric aortic valve surgery, including the early and midterm outcomes of AVNEO procedure, Ross procedure, and aortic valve augmentation. We retrospective analyzed of the early and midterm results of surgical AV disease treatment of 44 children in 5 cardiac surgery centers in Russia. 12 patients in AVNEO cohort, 10 patients in commissary with augmentation cohort, and 22 patients for Ross procedure cohort. The study design was approved by the ethics committees of the participating centers. We excluded from the study neonates, newborns, cases with dilated ascending aorta and subaortic obstruction. The median follow-up period was 57 months. We performed transthoracal echocardiography before and after surgery, and the transesophageal echocardiography like intraoperative examination. Besides the main parameters, we assessed the P gradient, the annulus fibrosus area, and the aortic regurgitation. We took primary and secondary points to check our results. Primary points included bypass time, cross-clamp time, intensive care unit stay, hospital stay, discharge, post-operative peak gradient, and discharge aortic regurgitation. And secondary points include in-hospital mortality, freedom from reoperation, midterm death, discharge aortic regurgitation in midterm follow-up, and discharge PPG in midterm follow-up. The median age of our patients was 9 years, and the youngest patient in ROS procedure cohort was in 2, and the youngest patient in AVNEO procedure cohort was in 3 years. We find 100% comparability between groups for age, for weight, for other echocardiographic and hemodynamic parameters. In assessment of previous aortic valve surgery, we found that more of these procedures was in CLEP cohort, and this procedure included balloon valvuloplasty. The peak pressure gradient before surgery was more higher in ROS procedure group. So the median bypass time was minimal in augmentation cohort and maximum in ROS procedure cohort. But we didn't find difference between groups in EQ stays assessment and hospital stay assessment. The number of concomitant interventions in the general population was 4.5% and included 1 prosthesis and 1 mitral valve repair in the AVNEO group. We did not meet acute renal failure, bleeding, strokes, or mediastinitis in any of the groups. The early postoperative discharge peak gradient score showed the lowest values of 8.9 millimeters in the ROS procedure cohort versus 16 millimeters of mercury in the AVNEO group. And there are more patients with discharge aortic regurgitation 2 degree on first day after surgery. We found in augmentation group. Secondary points. In hospital mortality was 2 children, 1 case in AVNEO cohort, a girl with severe heart failure in a 10-year-old girl with concomitant mitral valve surgery, and 1 case in the ROS procedure due progressive heart failure. No cases of in-hospital mortality were detected in augmentation cohort. The longest median follow-up was in the ROS procedure cohort, 68 months versus 42 months for AVNEO procedure and 48 months for augmentation procedure. No cases of midterm deaths were detected. A median survival over the entire follow-up period was 91, 195% for the AVNEO, augmentation, and ROS procedure group. And we didn't find the difference between group in median survival assessment. Discharge PPG was assessed between AVNEO and ROS procedure group, and the ROS procedure group showed us the excellent hemodynamics with H millimeters of mercury postoperatively P gradient, and similar with native aortic valve versus H in AVNEO procedure cohort. The cumulative freedom from reoperation was 160 and 100 for 20 months follow-up, and 100 for AVNEO, 30 and 95 for 40 months of follow-up, and total freedom from reoperation for 70 months of follow-up in AVNEO procedure group, and 30% freedom from reoperation for augmentation group, and 83% freedom from reoperation for ROS procedure group after 70 months follow-up. So, in conclusion, the ROS procedure has an absolute advantage in terms of hemodynamics parameters corresponding to those on the native aortic valve. The AVNEO procedure has a strong place in pediatric valve surgery, surpassing the freedom from reduced surgery of plastic procedures, and have comparable results with the ROS procedure in midterm follow-up. For objective assessment of the efficacy and safety of AVNEO in pediatric, we have to study this data on a large clinical material and with a longer follow-up period are required. Thank you for attention.
Bu gözəl sunumu üçün Əlişir bəyə çox təşəkkür edirəm. Thank you Əlişir İsmail bəyə for a great section. İndi isə sıradakı çıxış üçün buyurun Seymur bəy təqdimat üçün.
Bugünkü oturumun, indiki hal-hazırki oturumun son çıxışı Abuzər Aydın bəy. Decision making for repair in ischemic mitral regurgitation. Please, Aydın.
Dear Chairman and dear guests, first of all, I'd like to thank the organization committee for inviting me to this elegant congress to discuss this challenging topic. The mitral valve apparatus is a complex three-dimensional functioning unit that is critical to unidirectional heart pump function. Understanding normal mitral valve apparatus function and anatomy is essential to comprehend alterations in mitral valve disease and the rationale for treatment strategies, especially mitral valve repair. All patients with severe valvular heart disease being considered for valve intervention should be evaluated by a multidisciplinary heart valve team with either referral to or consultation with a primary or comprehensive valve center. In symptomatic patients with chronic secondary mitral regurgitation, transthoracic echocardiography is the initial diagnostic modality. Assessment of the coronary anatomy and myocardial viability may be helpful in management if ischemic MR is suspected. If surgical interventions and transcatheter mitral valve interventions is contemplated, transesophageal echocardiography determines suitability for the operation and guides the operation. Although there are many echo criteria for MR, we use frequently three of them. These are vena contracta, regurgitant volume, and effective regurgitant orifice area. Ischemic mitral regurgitation results from papillary muscle displacement, leaflet tethering, reduced closing forces, and annular dilatation. The prevalence of ischemic mitral regurgitation ranges from 1.6 to 2.8 million in the United States. Ischemic mitral regurgitation develops in approximately 50% of patients after an infarction, and moderate regurgitation occurs in more than 10% of patients. Moderate or greater ischemic mitral regurgitation develops progressively in more than half of patients after a myocardial infarction. Ischemic mitral regurgitation is associated with excess mortality regardless of management. Severe ischemic mitral regurgitation, the prognosis is grave, with rate of death ranging from 15 to 40% at 1 year. Operating mortality associated with either procedure has declined steadily during the past 5 years, but remains high. Tailored surgical approach will be required. The critical question is here, the pathology is complex, so that the treatment is complex. So, which patient is suitable for mitral interventions? The first question is, which patient can benefit? If the patient has viable myocardium and proximal coronary lesions, these can benefit mostly. And can patient tolerate the operation? Here's the critical question. Here's the critical paradigms are fragility of patients, organ dysfunctions, risk scores, Euro or STS score, or right or left ventricular function is important for making decision. According to the 2020 ACC guideline, optimal medical therapy has proven beneficial in patients with severe ischemic mitral regurgitation, presenting with heart failure and reduced left ventricular ejection fraction. The second choice is cardiac resynchronization therapy. Mitral valve repair provides a more durable correction of mitral regurgitation, but didn't significantly improve survival or reduce overall adverse events and readmissions, and was associated with early hazard of increased neurological events and supraventricular arrhythmias, and didn't lead to significant differences in left ventricular reverse modeling at 2 years. Another study, annuloplasty at the time of CABG, prevents further progression of ischemic mitral regurgitation, mitral reintervention, and left ventricular removal. There is another study that compares mitral valve repair and mitral valve replacement results. They observed no significant difference between groups in left ventricular reverse modeling or survival at 2 years. Mitral regurgitation reoccurred more frequently in the repair group, resulting in more heart failure-related adverse events and cardiovascular admissions. There is no difference between percutaneous repair or medical treatment groups, but transcatheter-based therapies may be an option for ischemic mitral regurgitation, especially poor left ventricular functions. The use of transcatheter mitral valve therapy is considered appropriate in high-risk patients with severe ischemic mitral regurgitation and reduced left ventricular ejection fraction, especially in patients with hemodynamic instability. It provides a less invasive approach that may be better in tolerated high-risk failure patients with ischemic mitral regurgitation and left ventricular dysfunction. As you see, we all know Carpentier classification system. I want to share my experience according to the Carpentier classification. Carpentier classification type 1, we can do restrictive annuloplasty alone. 10% of patients are in this group. Carpentier classification type 2, we can do restrictive annuloplasty alone, or restrictive annuloplasty plus subvalvular repair, or chordal sparing mitral valve replacement. I think restrictive annuloplasty plus subvalvular repair is a complex technique, so it needs more experience. Carpentier classification type TB is the most seen form of ischemic mitral regurgitation and also the most complex one. So the treatment is also complex. We can do restrictive annuloplasty alone, chordal sparing mitral valve replacement, or we can do restrictive annuloplasty plus supravalvular repair in this group. We have some echo predictors of restrictive annuloplasty failure. These are tenting height, tenting area, and interpapillary muscle distance. You see here the tenting height. If tenting height is bigger than 10 millimeters, it is the poor prognostic factor for mitral valve repair. If the patient has moderate ischemic mitral regurgitation, addition of mitral valve restrictive annuloplasty not associated with improvement in survival or reduction in adverse events, but it is associated with reduced persistent MR, and benefit may depend on degree of probe left ventricular remodeling. If the patient has severe MR and the valve anatomy favorable, if the valve has favorable anatomy, CABG plus mitral valve repair and or repair of subvalvular apparatus is a good option for this patient. If the valve anatomy doesn't support repair, we can do CABG plus chordal sparing mitral valve replacement. This is another treatment algorithm. As I said before, it's a good summary. If the patient suitable for annuloplasty, we can do restrictive annuloplasty because it's a very basic treatment and it can be done every cardiac surgeon. It doesn't need further experience, but annuloplasty and papillary muscle approximation need experience, and also we can do easily chordal sparing valve replacement. Left ventricle end-diastolic diameter bigger than 65 millimeter and decreased left wall thickness, basal aneurysm, and severe tethering are favors for chordal sparing mitral valve replacement. And also we have some techniques, supravalvular apparatus repair. One is basal cord cutting, second, papillary muscle approximation, third, application of infarct region, fourth, reposition of papillary muscle can be done, but these are need more experience and also experienced centers. This Congress dedicated to the memory of Haydar Aliyev. I also remember the national leader Haydar Aliyev with respect and mercy. Thank you for your attention. Have a good Congress.
Mən bu gözəl sunum üçün Abüzər Aydına təşəkkür edirəm. Thank you for great section, Dr. Abüzər Aydın. Və suallara dönmək istəyirəm indi. Suallarınız varsa, buyurun. Seymur bəyin sualları var.
Mən də hər üç çıxışçıya öz təşəkkürümü bildirəm. Thanks for your good presentations. I want to ask one question from Mr. Carlos. Type 1 dissection with both coronary artery dissection. Which of procedure, repair procedure, do you prefer like this situation, and like this situation was in your practice?
Excuse me, can you repeat the question because there was interference with the YouTube?
Good presentations. I want to ask one question from Mr. Carlos. Type 1 dissection with both coronary artery dissection. Which of procedure, repair procedure, do you prefer like this situation, and like this situation was in your practice?
Can you repeat the question because there was interference with the YouTube? Can you hear me now?
Mr. Carlos, can you switch off the YouTube? Switch off YouTube and close YouTube because mix of the sounds.
Confused with that. So hello?
Okay.
Yeah, because I thought it was on the Zoom, the discussion. So it's also on YouTube. Can you hear me now?
Mr. Carlos, can you switch off the YouTube? Switch off YouTube and
Yeah.
close YouTube
Uh,
because mix of the sounds.
Yeah, I'm on YouTube now. Can you hear me now? Hello? Hello? Can you hear me now?
Yeah, we are hearing you.
It was on the Zoom, the discussion, so it's also on YouTube. Can you hear me now?
Mr. Carlos, can you switch off the YouTube? Switch off. Mas problem değil yani danışabiliriz. Haha. Okay, Carlos, we are waiting your answer.
Can you hear me now?
Yeah, we are hearing you.
Okay, so back to the question. So it's also on YouTube. Can you hear me now?
Mr. Carlos, can you switch off the YouTube? Yoldaşlar, qoy danışsın, narahatçılıq yoxdur. Deyməyin, qoy danışsın.
Hello?
Mas problem değil yani danışabiliriz.
Hello?
Hello, Dr. Mesres.
Yes?
The discussion.
Okay, Carlos,
Yeah.
we are waiting your answer.
So I'm on YouTube. You want me on
Yeah,
YouTube or on Zoom? Okay, so back to the question.
Dear Professor, we are now on Zoom application. Please close your Zoom, your YouTube, please, and speak on Zoom, please.
Yeah, I'm on Zoom now. Is it okay? Can you hear me now?
Yes, we are hearing you. Very good.
So thank you very much. It was a bit of interference. I was not sure it was on both, which one. So I think that back to the question, if I did not understand badly, we just published that a few weeks ago. The problem with coronary bypass and dissection is that you have to individualize for every patient. I'm not the one who is going to recommend a specific type of repair, because we have seen patients in which we identify the coronary dissection on the preoperative CT scan, and in some patients we have discovered the dissection intraoperatively. So I think, of course, we know that it happens, and then we have to individualize the treatment for every patient. And sometimes we have to change the strategy intraoperatively. Among a number of cases, one of that I can recall now is a patient that we did a ventral operation, regular ventral operation, but when the patient was off bypass, suddenly there was a hematoma of the base of the heart, and then we have to revascularize the right coronary artery because this hematoma just redissected distally, although the anastomosis was for the ventral tube was okay. So I think that this is a problem that if you go through the literature, you've seen different types of options based on the preoperative CT, and then many times you can check if there is a problem with the coronaries. However, a number of times that has to be done intraoperatively because of the poor quality of the tissues, as you know, because there is an immediate intraoperative unrecognized problem. So I think that this is why, at least in our statistics, CABG increases morbidity and mortality, because some of these situations, they are totally unexpected. I think the value of preoperative CT scan when you do the dissection of the diagnosis of dissection is very high. However, a number of patients, you will need to readapt your strategy during the operation or even immediately after the operation where the patient is off bypass. So I think that it continues to be a challenge for us when we need to do associated coronary bypass. Sometimes it's only the right side, sometimes it's the left coronary artery system. So it may become, as you know, I think quite cumbersome and a big problem.
Okay, thank you Dr. Carlos. Sıradaki sorunu Abuzer Aydın Bey'e muhtemelen yöneltilmiş bir soru. Abuzer Hocam iyi günler. Türkçe rahatlıkla konuşabiliriz. Inferior MI geçiren, Türkçe cevaplayabilirsiniz. Daha kolay olur belki dinleyiciler için. Inferior MI geçiren hastada CABG kararı verilmişse ve mitral yetmezlik mevcutsa kapak ameliyatı için önceden kardiyak MRT yapmamız gerekiyor mu? Yani kardiyak MRT, magnet rezonans.
We couldn't hear you because your microphone is closed, I think.
No. It was open. Can you hear me now?
Yeah, I can hear you, dear professor, but I can't hear the chairmans.
Okay. Sorry, because I think they have the microphone mute.
Okay. Abuzer Bey, Türkçe mi sorayım, İngilizce mi sorayım? İzleyicilerin çoğu Türkçe rahatlıkla dinleyebildiği için. Dinliyor musunuz beni Abuzer Bey? Geliyor mu sesin? Abuzer Bey? Okey. Şu anda dinliyor musunuz?
Dinliyorum sizi.
Bir daha selamlıyorum sizi Bakü'den. Sizle birlikte olmak çok güzel. Soru şöyle. Inferior MI geçirmiş hastada eğer CABG kararı verilmişse, mitral yetmezlik varsa kapak ameliyatı için önceden kardiyak MRT gerekiyor mu? Böyle bir soru gelmiş.
Kapak ameliyat sualı.
Ben de size teşekkür ediyorum. Ben de İstanbul'dan sizleri selamlıyorum. Bu güzel kongreye davetiniz için de teşekkür ediyorum. Bu güzel bir soru. Inferior MI'larda özellikle biliyorsunuz asimetrik tethering daha fazla oluyor. Asimetrik tethering olması bizim için iyi prognoz işareti ama inferior MI'den ziyade sunumumda da bahsettiğim gibi esasında burada bizim tamir başarımızı, iskemik mitral yetmezliğinde tamir başarımızı etkileyen şey miyokardın viyabilitesini ölçmemiz gerekiyor. Bu çok önemli. Ventrikül duvar hareketlerini çok iyi gözlemlememiz gerekiyor. İkinci bir şey de ventrikül duvar kalınlığı çok önemli. Eğer ventrikül duvar kalınlığı azalmışsa orada reverse remodeling olma ihtimali daha yüksek. Dolayısıyla ve oradaki viyabilite de azalmış demektir. Transtorasik veya transözofajiyel eko yapmak bizim için yeterli olur ama özellikle sadece MR'la görüntülemek yerine MR PET yapılabilir ve böylece hem doku viyabilitesi hem de ventrikül fonksiyonlar hakkında daha fazla bilgi olur. Ama biliyorsunuz ki MR görüntülemeler son zamanlarda çıktığı için çok fazla tecrübe yok bu konuda. Bu konuda tecrübeli birilerinin bunu değerlendirmesi daha önemli tabii ki.
Çok teşekkür ederiz hocam. Buyurun Semir Bey, sizin bir sorunuz var.
Abuzer Bey'e bir soru sormak istedim. Asimetrik posterior tethering'de ring anuloplasti dışında yapılabilecek, yani sizin tecrübenizde yaptığınız hansısa bir əməliyyat serisi və yaxud da ki, əməliyyat növü, hansı əməliyyat növünə üstünlük verirsiniz diye bir soru ünvanlamak istedim.
Tabii ki. Şöyle, şimdi esasında simetrik tethering daha tehlikeli. Çünkü simetrik tethering'de hem anterior leaflet hem posterior leaflet birlikte etkileniyorlar ve burada daha büyük bir koroner lezyon var demektir. Hem LAD hem de hem de posterior'u besleyen hem bu sağ dominant olabilir veya sol dominant hasta olabilir. İkisi birden tıkanmış demektir. Dolayısıyla burada daha yaygın bir miyokard enfarktüsünden bahsediyoruz. Dolayısıyla bunların prognozu daha kötü. Ama asimetrik tethering sadece sol veya sağ dominant hastada o ilgili damarın tıkanmasına bağlı gelişmiş demektir. Burada asimetrik tethering'de son zamanlarda birçok çalışma, baktığımız zaman da birçok meta-analizde de şunu görüyoruz. Sadece restriktif annoplasti yapmak bu hastalarda çok sürviyi veya ventrikül fonksiyonlarını değiştirmiyor. Bize katkı sağlamıyor. ve bu hastalarda zamanla bu mitral yetmezliğin derecesi ileri derecede artıyor. Dolayısıyla bizim artık restriktif anneplastiye veya undersize anneplastiye mutlaka mitral aparatusun, subvalvular aparatusun tamirlerini eklememiz gerekiyor. Burada da bence birçok teknik var. Bunlardan bir tanesi sekonder kordaların kesilmesi, işte papiller kas adalelerinin birbirlerine yaklaştırılması veya enfarkt bölgesinin plikasyonu gibi teknikler var. Ama bunların içerisinde bence benim klinik tecrübemde en kolay yapılabilecek şey özellikle posterior leaflette sekonder kordalar ayırmak çok kolay değil. O çok daha fazla zaman istiyor. Ama anterior leaflette sekonder kordaları belirlemek daha kolay. Orada uygulanabilir bir teknik. Ama posterior leaflette bence çok dokunmamak lazım sekonder kordaları keserken. İkinci bir şey bence daha kolay yapılabilecek bir şey eğer ventrikül ileri genişlemesi çok fazlaysa yani ama burada tabii ki 65 milimetrenin üzerinde olmaması gerekiyor. Eğer end diastolik çap 65 milimetreyi geçmişse mutlaka o hastalarda kapak altı apareyini koruyarak mitral kapak replasmanı yapmak birinci tercih. Benim kişisel tercihim bu. Hem çünkü bizim burada cross süremiz de çok önemli. Bu hastaların zaten ventrikül fonksiyonları kötü. O yüzden hızlı ve efektif bir tedavi yapmak adına mitral kapak yani kapak altı apareyini koruyarak mitral kapak replasmanı yapmak bence daha ilk tercih olmalı. Ama ventrikül fonksiyonları iyi olan bir hasta, korunmuş olan bir hastada eğer anner dilatasyon fazlaysa burada ve asimetrik tethering varsa eğer sadece basit bir annoplasti ile bunu düzeltemiyorsak bence en kolay yapılabilecek yöntemlerden bir tanesi de papiller kasların birbirine yaklaştırılması diye düşünüyorum.
Çok teşekkür ederim.
Ben teşekkür ederiz hocam güzel cevabınız için. Şu anda Dr. Carlos, Dr. Cameron asked you, he has some question. Are there some standard approaches for non-A, non-B dissection?
You know that this new classification, I mean, not new, more than 20 years ago or so by Professor Hetzer in Berlin and Professor von Seges in Lausanne. I think, in my opinion, the non-A, non-B should be treated like the type A dissection. It is clear because although there are some differences in the prognosis or even in the way clinically this is presented, I think that for me, non-A, non-B should be treated as type A dissection, and because most of the times it's going to be confined in the aortic arch. There might be some retrograde involvement as well, but I think overall, when you have a look at what is in the literature, I think that in our experience also is that. So I think non-A, non-B should be treated like type A dissection with arch involvement.
Okay, thank you. Dr. Cameron, do you have any question about it? Thank you for your answer. Başka sual olan varsa, yoktursa mən bütün çıxışçılara öz təşəkkürümü bildirirəm, bütün izləyicilərə öz təşəkkürümü bildirirəm. Thank you for every speakers. It is a great to be with you. And yeah, one question. Where is I can soru görebilirim. Var mı senin sualın?
Yoxdur. Burada sual yox.
Okay. Bu şekilde benim o zaman böyle bir sorusu var. Optimal yaş dövrü. Sual aortan stenozu olan uşaqlarda cərrahi müdaxilə üçün optimal yaş dövrü nədir? Maybe they ask question to Alişir İsmailov. If there are aortic stenosis for children, is there any optimal age for operation? Are there any optimal age for operation for a children for aortic stenosis? Maybe Carlos, can you answer this question? Is there any optimal age for operation for aortal stenosis for children? Optimal age.
Yeah, I think the point is how symptomatic the child is. I think this has been out there in the literature for quite a long time. And I think that, of course, most of the times, like in many aortic other congenital defects, these small babies, they will have failure to thrive. They're not going to develop well. They're going to have these kind of symptoms when they fit. So I think it's probably or mostly related to which the symptoms are and how the patient goes into heart failure or not. I think everything has done from simple valvotomies to aortic replacements using the Ross approach and so on. But I think that this is going to be based on symptoms, and the neonates and babies are a bit different from a bit older children. But I think this is mostly based not only on the clinical aspects of the disease, but also on how the echo measurements, or even if you do a cath in a small baby, is going to show information. Most of these young fellows, they are not going to develop well since they start having symptoms that can be very, very early, soon after birth, or just as an older baby. It's I think this is also a matter of clinical judgments plus your echo, the eventually cath lab information as well.
Okay, thank you. Abzer Hocam, sizin bir eklemeniz var mı bu soruya?
Yani ben tabii pediatrik kalp cerrahisi yapmıyorum ama ben de Carlos Metres'e katılıyorum. Yani burada semptom önemli ve ne kadar geciktirebilirsek ameliyat yaşını, bence bu daha büyümüş çocuklarda kilosunu almış ve mümkünse erken çocukluk dönemine kadar ertelenmesinin daha uygun olduğunu düşünüyorum.
Bu Peri Hoca'ya çok teşekkür ederim böyle güzel bir soru için. Başka sualı olan yoktursa itirazı, sizin bir sualınız var mı Semih Doktor?
Bir sualımız yoktur.
Çok teşekkür ederim herkese böyle bir sunumu için, takdimatlar için. Thank you for everyone, every speakers. Thank you. I hope we will meet next time, next year without coronavirus and each other, we can see each other. Okay, thank you, everything.
The Azerbaijan Baku Heart Days is a premier event in Baku, but it's also one of the biggest or the biggest events now in the region, and it attracts a broad range of cardiac surgeons and some cardiologists even, and of course there's so many of the support personnel that benefit from attendance and education that comes with it. The nursing staff, the perfusionists, they have their own sessions now. They used to be blended, and now there's so much information that and it has grown to such an extent. They have their own sessions. The Also, the combination with the Eurasian Bridge Society has been, I think, beneficial to both groups because they benefit from each other's experience and perspective. But this conference has grown tremendously, and the impact has grown along with that for the region. And the international participation has continued to grow and grow. It's very impressive now.
Well, the role of any Congress is to examine what we're doing, to share best practices, to try and adjust medical care for the demands of the region and the problems that have to be solved in the region. Those of us who are not from Azerbaijan will, of course, not have a perfect idea of all the problems they face, but we have faced some problems in the past, and our solutions may be helpful to them as they go forward. I think that having the Congress in Baku is a center for a very, very large Turkic-speaking area. I mean, that includes Kazakhstan, Uzbekistan, Tajikistan, as well as Azerbaijan. So many of the medical professionals here have trained in Turkey, very few have trained in the United States. And this is a way of sort of sharing our view of things, which is a very long-standing medical community with a medical community that is still developing. It's very exciting. I think the future for things like this is very good. I think this is a very good place to have as a center for this entire area, which is 1/5 of the world's landmass. I think it bodes well for the future, and I'm excited about it.
Ümummilli lider Heydər Əliyevin anadan olmasının 98-ci il dönümünə həsr olunmuş Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi işə başlayıb. Dünyada mövcud olan COVID-19 pandemiyası səbəbindən Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyəti tərəfindən keçirilən konqres onlayn formatda baş tutub. 2 gün davam edəcək konqresin keçirilməsində əsas məqsəd Azərbaycanda kardiologiyanın və ürək-damar cərrahiyyəsinin inkişafına töhfə vermək, əcnəbi mütəxəssislərlə birgə fikir mübadiləsi aparmaq və tibb elminin bu sahədəki son yeniliklərini müzakirə etməkdir. 20-yə yaxın ölkədən kardioloq və kardiocərrahın mühazirəçi kimi iştirak etdiyi Bakı Ürək Günləri 7-ci Beynəlxalq Konqresində ürək-damar xəstəlikləri və onların müalicəsindəki ən aktual məsələlər, o cümlədən COVID-19 pandemiyasının ürək xəstəliklərinə təsiri və dünyanın aparıcı ölkələrində müalicəsinin təşkili müzakirə edilir. Kardiologiya və ürək-damar cərrahiyyəsi mütəxəssislərinin, həmçinin bu sahə ilə əlaqədar olan digər mütəxəssislərin konqresə izləyici kimi qatılmalarının tam sərbəst olduğunu deyən Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyətinin sədri Professor Kamran Musayev, Dünya Uşaq Kardiologiyası və Ürək Cərrahiyyəsi Cəmiyyəti ilə əməkdaşlıq çərçivəsində anadan gəlmə ürək qüsurlarının konqresdə ayrıca bir sessiyada müzakirə ediləcəyini bildirib.
Bu səfər də onlayn şəraitdə keçirilməsinə baxmayaraq biz Konjenital Ürək Akademiyası ilə, yəni anadan gəlmə ürək qüsurlarının Ürək Akademiyası ilə beynəlxalq təşkilat kimi biz onlarla əməkdaşlığa getdik və sabahki sessiyalarımızdan biri məhz onlarla birlikdə ortaq toplantı olacaq. Və bununla da mən elə hesab edirəm ki, sadəcə böyüklərin, yetişkinlərin ürək-damar xəstəlikləri deyil, uşaqlarda anadan gəlmə ürək qüsurlarının da diaqnostikasında və müalicəsindəki aktual problemləri biz dünyanın aparıcı mütəxəssisləri ilə müzakirə etmə imkanı əldə edəcəyik.
Kamran Musayev onu da bildirib ki, Azərbaycan Səhiyyə Nazirliyinin Elmi Tibbi Şurasının iclasında Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi davamlı tibbi təhsil verən tədbir kimi tanınıb və konqresə 16 kredit balı verilib. Bu o deməkdir ki, konqresdə izləyici kimi qatılan mütəxəssislər illik tələb olunan 48 kredit balının 16-sını toplaya bilərlər. Konqresdə iştirak etmək istəyən mütəxəssislər qeydiyyat üçün Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyətinin saytına və Konqresin təşkilat komitəsinə müraciət edə bilərlər. Xatırladaq ki, 2009-cu ildən etibarən hər 2 ildən bir Bakı Ürək Günləri Beynəlxalq Konqresi təşkil edilir.
Hamınızı salamlayırıq. İcazənizlə biz ikinci sessiyaya başlayaq. İkinci sessiya bizdə qarışıq sessiya olacaqdır. İlk çıxışı Dr. Carlos Mestreslə başlayırıq. Ürək cərrahiyyəsi pandemiya dövründə çox aktual və çox önəmli bir mövzuya toxunacağıq. Pandemiya zamanı nələr olur və bizi nə gözləyir? We start the next session, big session. The first speaker, Dr. Carlos Mestres, speak about cardiac surgery during the pandemic. What's happened? Please, Dr. Carlos.
Good afternoon. Again, ladies and gentlemen, let's go to the next topic that I have been asked to deliver to you, which is surgery during the pandemic. What happened? I'm going to give you our perspective from the University of Zurich in Switzerland. I have no conflicts of interest. And this is the brief outline for today. So where we are, what was the status for us in Switzerland, and the role of the cardiac surgeon during the pandemic. So when we have a look at the world map, in the past 20 years, the epidemics, major epidemics, they have been concentrated in Africa. This is what this world mapper has defined for us. Until the situation changed in early 2020 when COVID-19 came into the scene. And in the beginning, the first 2-3 months, that was the map of the world. So with most of the cases recorded, registered in the Far East, as you could see in the map, and with an increasing incidence in the Middle East and Europe. And a few months later, at the end of April, early May, you could see that the most of them, they concentrated in Europe, and then they, on the left-hand side, especially North America, was suffering at the time from the new infection. And as of May 2020, there were more than 3 million tests confirmed with a mortality rate of 7%. And in Europe, most of the mortality was concentrated in the UK, France, Italy, and Spain. And that was April, May 2020. 1 year later, and this is updated in January, February, this is the distribution. North and South America, they have huge numbers there. Also Europe, which is still in the high side, and India with China, and those countries with a control of the infection. And that was the coronavirus mortality, also updated early this year. As you could see, that most of the deaths are concentrated in the very dark blue sites in North, South America, and Europe as well. And as of May 9, 2021, we had 160 million cases with a mortality rate of 2%, which was much lower than a year ago. And that was the report from the WHO with the COVID cases by a region of the world and mortality as well. And it's easy to understand why. We probably did not know from the H5N1 influenza epidemic in 2003-4-5, and this article in the New England Journal of Medicine just showed that it would be prudent to develop robust plans for dealing with pandemics, and we understand that in current times this spreads quite easily all over the world. In our experience in Zurich, the University of Zurich and Switzerland, that was the situation on the 9th of May this year. So overall, we had 670,000 cases declared with a mortality of 10,000 patients, which is a mortality of less than 2% for an 8 million people population country. And the evolution by week since the beginning is that you could see that in the beginning, the first wave, there was a massive concentration of cases on week 13 at the beginning of the pandemic. And overall, and these are data from a few days ago from the Ministry of Health, in terms of hospital capacity in Switzerland, there is a total occupancy of 77% in terms of hospital capacity, and 4% of those beds are COVID-19 patients. And with regards intensive care units in Switzerland, the occupancy is 75%, and out of them, 23.4% are COVID-19 patients. And this is how is the situation as of 7th of May, a few days ago, in Switzerland and Liechtenstein. So we had 266 cases per 100,000 inhabitants mean, with this range that you can see here. And on the other hand, the laboratory confirmed deaths, as you could see here, in this site after the second wave. And we have about 1 million fully vaccinated people. These are epidemiological data. This timeline was a general one for our institution. So at the University Hospital in Zurich, the CEO, Professor Zun, a cardiac surgeon himself, started on the strong measures in cancellation of every single activity there until mid-late March. All the activities were canceled by the Zurich Department of Health, and the activity resumed at the end of March, early April. And all these restrictions from March 2020 that are still active as of today, 23rd of May 2021. And these recommendations are all over and will be here for quite a bit of time. In terms of the impact on our activity during the first wave, as you can see here, and this is the activity between the 28th of February and the 1st of May. So these 2 months and a few more days, there was a decrease, of course, in major surgery, as you could see here. And we were able to still operating patients for emergencies or urgencies like coronary bypass in unstable patients, aortic dissections. We did just 3 transplants and a number of endocarditis. And 1 year later, during the second wave, this is between early December, at the end of January, the beginning of February, there was also a significant decrease in volume, although again, we were able to keep this activity going on because of urgent myocardial revascularization, aortic dissection, and as you could see here, different types of operations. In terms of cardiac surgery, the problem we know when there is a flourish disease and respiratory insufficiency, we need to support these patients. This is during the first wave, the European trend for ECMO support in COVID-19 patients. As you could see, regardless of the country, the configuration was mostly veno-venous in 92%, meaning that was basically a respiratory failure, and those patients require respiratory support. We published our first experience during the first wave with 9 patients. That was published a few months ago. And we were ready for that because the CEO took the decision to purchase more ECMO equipment and more oxygenators, of course, foreseeing that that could be the possible evolution in the future. And during the second wave, This was the European trend for ECMO, according to Euro-ELSO. It was between September and March of this year, an increase in the number of patients requiring ECMO for respiratory support. We also published the initiation of our inter-hospital ECMO transfer program for critically ill patients. And overall, our experience during the first year between March and April 2021, during the first year of the pandemic, we have implanted in our hospital, University Hospital, 35 patients. You could see 83% of those patients, they required a veno-venous configuration. 7 were brought by helicopter, and a survival rate at the moment has been 77%. We still have 4 patients in the hospital. And this is the trend, which is also slightly upwards in the last wave, the third wave of the pandemic between March and middle April this year. Finally, I'd like to briefly discuss the role of the surgeon during the pandemic. First of all, we need to understand that cardiac surgery, it is not in the front line of COVID-19 patient care. This is clear. We need to understand that to understand the whole picture. At the individual level, we need to prevent. It's very clear that I think everybody, all of us, we have done that in different types of protective equipment. And at the population level, of course, an aggressive approach to delay transmission by implementing the public health measures, which have been discussed extensively, inclusive of home lockdown in different parts of the world. In Switzerland was not that strong like in other countries in Europe, like France or Spain or Italy, but this has been, of course, quite effective. It is clear that COVID-19 had an impact on cardiac surgery in Zurich, absolutely yes, too, because of the limited ICU bed availability, because there is a central command for hospital bed control. Of course, cancellation and postponement of elective cases, and we had to survive, of course, on urgent operations like type A dissections, endocarditis, and things like that. And we have followed exactly what everybody has done. The Swiss Society for Cardiac Surgery has also, like most of the national societies, issued some recommendations, guidance statements for surgeons to behave before the COVID impact in every single hospital all over the world. There might be some further considerations, like you could see here, avoiding CO2 insufflation, the aerosol formation with cauteries, heat exchangers, transportations, chest tubes, and so on. And this is something that probably each and every one of us has considered and discussed during the pandemic so far. It is clear that, at least for us, like everybody probably, the pandemic situation means that any patient is theoretically a COVID-19 patient. And of course, a number of hints to increase the suspicion when facing surgery. We have also seen, according to the literature, an observed mortality which seems to be increasing a bit. And what is clear is that disease will change cardiac surgery practice in the world in the future. This is a very recent report, I think, from a couple of weeks ago, a combined article between tertiary aortic centers in the aortic in China and the United States. And at the end, the point is that they were addressing type A dissection during COVID pandemic. And it is clear that probably we need to change our mind with regards to specific subgroups of patients with aortic dissection because of COVID. And this is clear when they consider low-risk patients and high-risk patients that might or might not receive operative treatment and different approaches. And this is something to explore. We also ran this survey in 61 hospitals worldwide among professionals in cardiac surgery practice with regards to the effects of COVID-19, and the conclusions were that it has been a profound impact of COVID-19 on cardiac surgery practice in terms of resource allocation, staff infection, surveillance policies, and surgical outcomes. I think that was a very interesting information that we were able to draw. And again, going back to the most important points, bed availability, cancellation of elective patients, survival on urgent operations, and also depends on the region and the country and even the hospital, an impact on training and education that has not been our case so far. I would like to conclude by telling, and probably you would agree, that COVID-19 puts healthcare systems under extreme stress. Healthcare workers are those probably with the highest exposure risks. The respiratory support, as we have seen, has been increasingly required. The restrictive measures distort regular surgical schedules, and non-urgent activities probably need to be reorganized with, of course, associated risk in specific pathologies. Which is going to be the COVID aftermath. We are probably going to live with uncertainty and mortality. There will be much more control and biosecurity regimes. There will be much greater biological and medical surveillance. We might only have privacy at home. There will be state security protocols. We know that is a fact in airports, mass gatherings, and so on. There will be, of course, uncomfortable living adjustments. And it is probably because of that that there will be much greater control on our personal lives. So thank you very much again, and then I will be, of course, available for questions and discussion. Thank you very much.
Thank you, Dr. Mestres. Thank you for this very interesting and very actual lecture for us, because all of us have more problems about in COVID patients. And we are going to the next presentation. Our next presentation is implantation of MCS devices as a bailout strategy for countries with shortage of organ donors. Lecture is Yuri Pia from Kazakhstan.
Dear Chairman, Presidium, dear ladies and gentlemen, I'd like to thank the organizers for inviting me to be part of this wonderful Congress and for the opportunity to share the information about our clinic and our experience. Today I'll talk about implantation of ventricular assist devices as a bailout strategy for countries with shortage of organ donors. There is no conflict of interest. And first, let me tell you briefly about our clinic, the National Research Cardiac Surgery Center located in Astana, now known as Nur Sultan in Kazakhstan, was established 10 years ago. We have 200 beds, including 24 adult intensive care units and 12 pediatric intensive care units. There are 6 operating rooms for open heart surgeries and 5 cath labs. We provide diagnosis and treatment of all heart conditions for adults and children, including cardiology, arrhythmology, interventional cardiology, radiology, and of course cardiac surgery. And we are the coordinated center to countrywide cardiac surgery service. We are JCI accredited in 2014 and re-accredited in 2017 and March this year. We also were certified by the CCPC for heart transplant and mechanical circulatory support for heart failure program. In total, we perform approximately 9,000 procedures per year. Of those, around 7,000 percutaneous coronary interventions and 2,000 open heart surgery. In 2011, we established the program of surgical treatment end-stage heart failure using short and long-term mechanical circulatory support devices. Until 2011, unfortunately, Kazakhstan didn't have a heart transplant program. The patients with chronic heart failure were on medical therapy only. But opening of a modern hospital with the latest equipment, which also had a multidisciplinary team and trained worldwide, and mainly having a financial support from government helped us establish the heart failure program in our country. Of course, there was a lot of help from international partners, for example, such as Ege University from Turkey, IKEM from Czech Republic, University of Minnesota from US, and etc. Here you can see how our heart failure program developed over the years. We implanted our first short and long-term ventricle assist devices in 2011. Then the following year, we performed our very first heart transplant. In 2013, we used the Transmedics organ care system for the first time in our country. Starting from 2014, we took part in the HeartMate 3 new generation VII trial. We also performed a few lung transplants since 2015. Implantation, the total artificial heart CARMAT in 2017, and in 2018, we performed first in the world implantation fully implanted ventricular assist device. I will tell you more in detail about this technology later in my presentation. I can now confidently say that over the course of our development of our heart failure program, we established that reliable and durable mechanical circulatory support devices can now serve as an alternative for heart transplantation. This is a number of mechanical circulatory support devices, implants in heart transplant in our clinic by year. In total, 82 heart transplants since 2012. As you can see, mechanical circulatory support devices can be used interchangeably with the heart transplantation. In this slide, you can see overall watt experience by application, either LVAT, VII, or total artificial heart. A total of 390 patients were implanted. The vast majority of our implants are LVATs, and you can see the breakdown of the type of devices here. Since 2014, we have been taking part in different clinical trials using HeartMate 3 device, and we came to the conclusion that implantation of this device was found to improve results and associate with 2 years outcomes comparable to heart transplantation in patients with advanced heart failure. As you can see from the survival analysis results here, HeartMate 3 survival matches the heart transplant survival. So far, a country with a shortage of organ donors, this device is literally a lifesaver for us. Another revolutionary mechanical circulatory support device that we implemented in our clinic is CARMAT, Total Artificial Heart. It's an invention of very famous Professor Alan Carpentier and was engineered by Airbus Group. The uniqueness of this device lies in its three key innovations. It's biocompatible, it's pulsatile, and has auto-regulation function. I will talk more in detail about this innovation in the next slides. This common device, external and internal structure. The external structure is very similar to regular mechanical circulatory support devices. Regarding internal components, the surface of the device that touches the blood is made of biocompatible tissue. Due to this fact, the device has potential to reduce thromboembolic complications. Also, each ventricle is split in two parts, one for the blood flow and one for actuator fluid, which ensures pulsatility of the device. The cardiac output changes dependent on patient's activity, which shows the auto-regulation function. The main CARMAT total artificial heart is the main idea of CARMAT total artificial heart is to mimic the physiology of a biological heart. In total, in our clinic, we performed 3 cases of CARMAT implantation. All 3 patients were implanted with CARMAT total artificial heart as a bridge to transplant. Eventually, they were all successfully transplanted. This is the picture you can see in this slide of the device after it was explanted. In December 2018, we performed a unique surgery in our clinic in Kazakhstan, implantation of a fully implantable ventricular assist device. It is a hybrid system made by Leviticus and Jarvik companies. This is an X-ray image taken right after the surgery. And you can see in this picture the LVAD itself and the coil, internal coil implant around the lung and the battery and controller as well. In December 20, in this video, you can see the first patient we implanted with a fully implantable ventricular assist device. The system provides, as you can see, a lot more freedom to the patients. As you can see, they can even swim. Of course, it would not be possible without effective collaboration between the international team of surgeons, engineers, and other specialists, as you can see in this picture, from different countries. Thank you very much for your attention.
Thank you, Dr. Pierre, for excellent presentation and favorable results. European nəticələri qulaq asdıq, çox gözəl nəticələr və yeni bir strategiyalar barədə bizə məlumat verdilər. Üçüncü çıxışçımız minimal invaziv assist device implantasiyaları barədə mövzuda çıxış edəcəkdir. Professor Dr. Ümid Kervan. The third speaker, Dr. Ümit Kervan, minimal invasive strategies for VAD implantation.
Dear Chairman, colleagues, Professor Dr. Kamra and Ramil, thanks so much for inviting this meeting. Our topic is minimal invasive LVAD implantation today. As you know, standard implantation of LVAD system is performed using the full median sternotomy approach. Median sternotomy may provide excellent exposure to heart and great vessel. Although this approach has successful, it may increase risk of postoperative bleeding, infection, complication from the reduced sternotomy in patient breast transplantation. Furthermore, opening the pericardium may associate with the increased risk of right ventricular failure. As a result of technological developments, has enabled minimal invasive surgery for the implantation, explantation, and exchange of ventricular device. The what-related success is mainly based on two important factors. The first, novel technology, and the second, increase the surgical experience leading to lower complication rate and better outcomes. The LVAD insertion is divided in 3 steps. Inflow cannula insertion and outflow graft anastomosis could be done with the minimal approach. There are 2 inflow cannula site approach for the minimal invasive technique. The left costal incision and the left anterothoracotomy at 5th or 6th intercostal space. Outflow graft anastomosis could be done multiple technique and different localization, which include right thoracotomy, upper G sternotomy, subclavian or the ascending aorta anastomosis, and the abdominal aorta, descending aorta anastomosis could be done. I would like to give the information about our minimal invasive procedure. After general anesthesia and single lumen tube endotracheal intubation, transesophageal echocardiogram is performed. Femoral artery in the vein are used to establish cardiopulmonary bypass. If patient has the peripheral arterial disease, usually we use the right brachial artery or subclavian artery for cannulation. Our first step is performing upper G sternotomy. We check whether we can put the side clamp descending aorta. After that, we perform about 5 or 7 centimeter anterothoracotomy incision at the 5th or 6th intercostal space. Our goal is the pericardium remain mainly closed, and we care about thoracotomy wound infection. The inflow site is echocardiographically marked on the left ventricle by using the finger push on the apex for mimicking inflow of cannula. Epical sewing ring is determined formally and marked all the around with the surgical pin, and this is the guide when we pass suture. We put about 12 Etimond or polypropylene suture with the fat on the apex. After completing the apical stitch, all individual the stitch are passed through the ring like the white replacements. After the put the apical and the stitch, first we knocked one suture at each quad. After that, 2 surgeons moved to the tie stitch at the same time. We apply the compression on the ring while tying the stitch, reduce the ventricular tension. After off-pump placement of apical sewing, heparin is given. Our goal is activated clotting time about 300. We don't cut the thread of the one suture at each quad. Sorry. We can stabilize the left ventricular apex with feature insist of your finger during insertion of the device. This maneuver allows the smaller throughotic incision. As you know, the normal screwdriver remains short and obvious, and the female patient would have designed three different ranges of the special instrument for minimal invasive surgery. We install this tool type of the screwdriver. At the placement of the device, let the perfusion technician feel the left ventricle. Therefore, it's easy to check the bleeding from the left ventricle apex. Afterward, let the perfusion technician empty left ventricle. Thus, the heart can be placed in back to pericardial space. This maneuver allows the closer pericardium. We try closer pericardium over the left ventricle as device whenever possible. But it's one important point. We check the position between the inflow cannula and the mitral valve with the echo. Rarely we need to cover the left ventricle with the membrane. And outflow anastomosis and side ascending aorta. The successful implantation LVAD in patient with the previous median sternum, especially high-risk patient, remain challenged. Professor Özberen and colleagues from the University of Ege, they have a huge experience about the descending aorta anastomosis. They reported that result of the two texts were similar. Why we prefer minimal invasive technique approach? As you know, right ventricular failure is one of the biggest problems after LVAD implantation. Right ventricular failure is strong independent determinant of the outcome. Professor Dr. Kormoz and colleagues show that relationship between the bleeding and the right ventricular failure. And also, Dr. Arnsworth and colleagues reported that preserving of pericardium offers a potential protective role in the maintaining right ventricular geometry and the pressure volume relationship. You know, the NIVS trial, lateral trial is a multi-center prospective randomized single arm. Their author reported that mean length of the hospital stay was significantly short in median sternum patient. I would like to give some result about our case. We have about 80 minimal invasive LVAD implantation. Minimal invasive technique was favored in patients with worse right ventricular function and a low intermax profile to provide the need of postoperative right ventricular support at the bleeding. As you see, our right ventricular failure incidence about 5%. There are our opinion that there are two reasons for the result. The first, preserving the pericardium offer the potential protective role, maintain the right ventricular geometry. And the second, the right ventricle is protected, maintain the heart's normal anatomic position. Because the heart doesn't have to be elevated, pulmonary arterial obstruction and the coronary perfusion are provided, all of which have been implanted as putative mechanism in the right ventricular failure using median sternum approach. And our first-year survival is 89% in conventional median sternum case and 91% minimal invasive groups. The limitation of minimal invasive approach, visual control of contractive function, especially of the right ventricle, is reduced. Minimal invasive surgical approach is technical, more difficult to performed on full median full sternotomy. Estimation of the exact length of the autograft is more challenging than the conventional technique. And the second important question, right ventricular failure after minimal invasive airway implantation. Our strategy is, if patient has right ventricular failure after minimal invasive implantation, we use 8 millimeter graft, Dacron graft, at site anastomosis to the pulmonary artery for outflow ecmocalination through the upper G sternotomy. We use the right femoral vein for inflow calination to ECMO. Left thoracotomy approach might provide LVAD extraction explantation. This boy is 9 years old. If we implanted the LVAD 4 years ago, ventricular function improved after 3 years. We extracted LVAD last year. And conclusion, less bleeding, rate case minimal dissection, pericardial incisions is minimal. The heart doesn't have to be elevated. That means decreased right ventricular failure. Also, less sedation for the transplant surgery, faster mobilization and rehabilitation. All of result that mean better survival. Thanks so much.
Thank you, Dr. Ümit Kervan, for this very interesting presentation. And we are going to the end session, discussion and question session. Çok teşekkürler Ümit Bey bu güzel prezentasiyanız üçün. Və sorular və discussion'a keçirik, müzakirələrə keçirik, əziz izləyənlər. İlk sualım Ümit Bey'e bitirdiyiniz üçün bu sualımı vermək istəyirəm. Sizin təcrübənizdə, praktisinizdə, COVID xəstələrində VAD implantation təcrübəniz varmı? Bizdən bölüşərdiniz zəhmət olmasa.
We don't have experience about the COVID patient with the LVAD implantation. As you know, the COVID diseases, inflammatory and thrombosis. And we care about thrombosis in the LVAD patient. We don't have the experience.
Not experience, okay.
Thank you.
The next question, Dr. Carlos Mestres. Hello, we're happy to see you online in Baku. Doctor, we have one question. We see the interesting map of change of COVID from the Earth and the change of phase of COVID. What do you think, what we need to know about COVID-19? What we do in coronary surgery? What's new realities in coronary surgery in COVID-19?
Thank you. Our policy has not changed that much. Of course, we know that at the beginning of the pandemic, there were a lot of issues. We probably all over the world, we didn't know what to do. That was unexpected. I think most of the countries anyway had prior experiences in 2002, 2003 with the SARS, and at least there were countries, for instance, like Spain or Switzerland, they had, the Ministry of Health had a number of prevention measures already published years ago, but that was a really big thing. And then overall, in terms of the strategy, one thing is that a number of vets or many vets were dedicated to COVID patients, but on the other hand, the way we conducted the surgery has been exactly the same. So for coronary bypass, for valves, for transplants, for emergencies, for aortic dissection, other than the preventive measurements, the measures, the anesthesia controls, everything has been exactly the same. We have not changed the anticoagulation therapy,
the coronary bypass goes as usual with antiplatelets. We did not observe any more thrombotic phenomena in LVAD patients. A number of them were performed in this past year of the pandemic, and also not changes with regards to transplantation. I think that the surgical policy in terms of what you do and how you do it has been more or less the same that we had before of the pandemic, inclusive the regular types of medications that we give to the patients on a regular basis. It is true, and I think Dr. Kevan just say that thrombosis, we know that this is a main thing, but I think it mostly applies to those patients with in really bad respiratory condition. We had, I think, 2 patients in which angiovac was used to remove thrombus from the inferior vena cava, and those patients, in one of them, there was a thrombosis of the system that was well handled. But other than that, I think the overall policy for the cardiac surgical patient from valve to coronaries has been the same that before of the pandemic.
Thank you, Dr. Mestres. Next question for Dr. Mestres. Are there some standards, recommendations for non-A and non-B dissection?
This is also a good question. We have published that the European Association of Cardiothoracic Surgery, in conjunction with the European Society of Vascular and Endovascular Surgery, we published that about just less than 2 years ago in the European Journal. Overall, I think that there are no major differences that when you treat acute type A dissection, because if you remember the publication of, for the first time, of the non-A, non-B dissection was a very specifically concentrated dissection on the aortic arch without a clear entry point in the ascending or in the descending. But at the end, I think we briefly discussed that before this morning. For us, the non-A, non-B has to be treated, should be treated like the acute type A dissection. And if you want, the regulations, or the recommendations are in this article from the 2 joint societies in Europe. I think that was very useful discussion anyway.
Thank you very much.
Növbəti sual vermək istəyərdim Dr. Ümid Kərvan və Carlos Mestres'e. We have one question for Dr. Ümid Kərvan and Carlos Mestres. I know you are both of them active surgeon. Situation, patient after cardiac surgery have COVID in hospital, COVID. What are you do?
Please, Ümid.
And we have some case experience about the COVID after the cardiac surgery, and that were dramatically. The all case death. Yes, we have seen about 2 or 3 days, and we have seen the multi-organ failure. The patient will be all the patient.
And Dr. Carlos Mestres.
Thank you. That was very interesting. We have been very lucky. We have operated, I think, about 15 patients that had COVID infection, but a few months before the operation, because these were elective patients. For instance, patients that they have COVID infection with some respiratory issues in November or December that were operated, for instance, in March or April this year. And these patients, they don't differ so much from the normal patients. We had just one patient that I can't recall now that had respiratory issues post-operatively because of COVID. And actually, the interesting fact was that during the operation, for unknown reasons, and this patient got tested before, was negative, there were some issues with respiratory management, where there were some the patient required higher flows of oxygen. The oxygenation was in the low side, and then in the postoperative period for a couple of days, we noticed some infiltrates, and the patient finally tested positive. So it was a very interesting situation. But anyway, we were also lucky because the patient did survive. He did not go on organ failure. So I think that's something that may eventually happen. And at least in our experience, we have been extremely, extremely lucky that we did not have that bad experience that has been reported by other colleagues. I understand what Dr. Mitkervan said, that in this particular patient, there was organ failure, which is something, of course, as we know, of extremely poor prognosis anyway. But again, I have to say that we have been very, very lucky, and we did not have major issues with these patients. Of course, patients who had COVID testing positive that require respiratory support, and as I said before, we had 35 patients on ECMO at the moment, because that was recorded a few days ago. We have 38 patients implanted with ECMO, but that was, of course, different thing than the pure cardiac surgery patient.
Thank you, Dr. Mestres. Ve son sorumuz Ümit Bey'e. Demin sunduğunuz sunumda sol assist device kullandığınız hastalarda sağ gitmezlik yaranarsa, oluşursa sağ assist device icra ettiğiniz hastanız oldu mu hiç?
Minimal invazif mi yoksa normal hastalar?
Minimal invazif, yine aynı strateji yani.
We have experienced right ventricular failure after minimal invasive surgery. Usually we use the 8 mm graft anastomosis to main pulmonary artery through the upper G sternotomy for the outflow, and we use the right femoral vein for inflow cannula. We have two cases. After 5 or 7 days, we're weaning the ECMO.
Thank you, çok sağ olun.
Usually we prefer the minimal invasive technique. It's the worst right ventricular failure and the low intermittent profile.
Thank you, çok sağ olun. Bu sesiyamızda sonuna yaxınlaşdıq. Növbəti sesiyaya keçəcəyik.
Thank you for all the speakers. See you in the next meeting.
Artıq bu gündən etibarən Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyəti tərəfindən Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi keçirilir. Tədbir ümumi lider Heydər Əliyevin anadan olmasının 98-ci il dönümünə həsr olunub. Bu tədbirin keçirilməsi ənənəyə çevrilib. 2009-cu ildən etibarən hər 2 ildən bir təşkil olunur.
Bu dəfəki konqresimiz təəssüf ki, bildiyiniz kimi bütün dünyada mövcud olan koronavirus pandemiyasından ötürü onlayn şəraitdə keçirilir. Buna baxmayaraq biz çalışdıq ki, bütün o onlayn keçirilmənin yaratdığı problemlərə baxmayaraq ciddi, dolğun və yüksək səviyyəli bir konqres təşkil edək. 2 gün müddətində davam edəcək bizim konqresimiz. Dünyanın 15-ə yaxın ölkəsindən qonaqlarımız onlayn şəraitdə bizim konqresə qoşulacaqlar və ürək-damar cərrahiyyəsinin, o cümlədən kardiologiyanın aktual məsələlərini müzakirə edəcəklər.
Eyni zamanda konqresin 2-ci günündə koronavirus pandemiyası və kardioloji mövzular haqqında müzakirələr aparılacaq.
Xarici ölkələrdən çox dəyərli həmkarlarım öz təcrübələrini bölüşdürəcəklər ki, bu pandemiya şəraitində kardioloji və kardiocərrahi xidmətlər necə təşkil olunmalıdır? Həm xəstələr üçün, həm tibb personalı üçün. Digər tərəfdən biz hər dəfə çalışırıq ki, konqresimizdə bəzi yeniliklər edək və konqresimizin elmi-praktik səviyyəsini daha yüksəldək. Bu dəfə də biz onu bacardıq ki, beynəlxalq bir təşkilat olan Anadan gəlmə ürək qüsurları akademiyası deyilən bir beynəlxalq təşkilat var. Biz onlarla əməkdaşlığa getdik və bir sessiyamızı onlarla ortaq toplantı şəklində təşkil edəcəyik.
Beləliklə, anadan gəlmə ürək qüsurlarının həm diaqnostikası, həm müalicəsi mövzusunda fikir mübadiləsi aparılacaq. Qeyd edək ki, Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi sabah da daxil olmaqla 2 gün ərzində keçiriləcək.
Компания Кырка в процессе своего развития стала одним из ведущих мировых производителей дженериков. Благодаря постоянным капиталовложениям в исследования и разработки мы успешно принимаем все вызовы, связанные с патентами и технологией производства. Многочисленные лабораторные тесты проводятся нами.
The Azerbaijan Baku Heart Days is a premier event in Baku, but it's also one of the biggest or the biggest events now in the region. And it attracts a broad range of cardiac surgeons and some cardiologists even. And of course, there's so many of the support personnel that benefit from attendance and education that comes with it. The nursing staff, the perfusionists, they have their own sessions now. They used to be blended, and now there's so much information that and it has grown to such an extent. They have their own sessions. The also the combination with the Eurasian Bridge Society has been, I think, beneficial to both groups because they benefit from each other's experience and perspective. But this conference has grown tremendously, and the impact has grown along with that for the region. And the international participation has continued to grow and grow. It's very impressive now.
Well, the role of any Congress is to examine what we're doing, to share best practices, to try and adjust medical care for the demands of the region and the problems that have to be solved in the region. You know, those of us who are not from Azerbaijan will, of course, not have a perfect idea of all the problems they face, but we have faced some problems in the past, and our solutions may be helpful to them as they go forward. I think that having the Congress in Baku is, Baku is a center for a very, very large Turkic-speaking area. I mean, that includes Kazakhstan, Uzbekistan, Tajikistan, as well as Azerbaijan. So many of the medical professionals here have trained in Turkey, have trained in some, very few have trained in the United States. And this is a way of sort of sharing our view of things, which is a very long-standing medical community with a medical community that is still developing. It's very exciting. I think the future for things like this is very good. I think this is a very good place to have as a center for this entire area, which is 1/5 of the world's landmass. I think it bodes well for the future, and I'm excited about it.
Ümummilli lider Heydər Əliyevin anadan olmasının 98-ci il dönümünə həsr olunmuş Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi işə başlayıb. Dünyada mövcud olan COVID-19 pandemiyası səbəbindən Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyəti tərəfindən keçirilən konqres onlayn formatda baş tutub. 2 gün davam edəcək konqresin keçirilməsində əsas məqsəd Azərbaycanda kardiologiyanın və ürək-damar cərrahiyyəsinin inkişafına töhfə vermək, əcnəbi mütəxəssislərlə birgə fikir mübadiləsi aparmaq və tibb elminin bu sahədəki son yeniliklərini müzakirə etməkdir. 20-yə yaxın ölkədən kardioloq və kardiocərrahın mühazirəçi kimi iştirak etdiyi Bakı Ürək Günləri 7-ci Beynəlxalq Konqresində ürək-damar xəstəlikləri və onların müalicəsindəki ən aktual məsələlər, o cümlədən COVID-19 pandemiyasının ürək xəstəliklərinə təsiri və dünyanın aparıcı ölkələrində müalicəsinin təşkili müzakirə edilir. Kardiologiya və ürək-damar cərrahiyyəsi mütəxəssislərinin, həmçinin bu sahə ilə əlaqədar olan digər mütəxəssislərin konqresə izləyici kimi qatılmalarının tam sərbəst olduğunu deyən Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyətinin sədri Professor Kamran Musayev Dünya Uşaq Kardiologiyası və Ürək Cərrahiyyəsi Cəmiyyəti ilə əməkdaşlıq çərçivəsində anadan gəlmə ürək qüsurlarının konqresdə ayrıca bir sessiyada müzakirə ediləcəyini bildirib.
Bu səfər də onlayn şəraitdə keçirilməsinə baxmayaraq biz Konjenital Ürək Akademiyası ilə, yəni anadan gəlmə ürək qüsurlarının Ürək Akademiyası ilə beynəlxalq təşkilat kimi biz onlarla əməkdaşlığa getdik və sabahki sessiyalarımızdan biri məhz onlarla birlikdə ortaq toplantı olacaq. Və bununla da mən elə hesab edirəm ki, sadəcə böyüklərin, yetişkinlərin ürək-damar xəstəlikləri deyil, uşaqlarda anadan gəlmə ürək qüsurlarının da diaqnostikasında və müalicəsindəki aktual problemləri biz dünyanın aparıcı mütəxəssisləri ilə müzakirə etmə imkanı əldə edəcəyik.
Kamran Musayev onu da bildirib ki, Azərbaycan Səhiyyə Nazirliyinin Elmi Tibbi Şurasının iclasında Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi davamlı tibbi təhsil verən tədbir kimi tanınıb və konqresə 16 kredit balı verilib. Bu o deməkdir ki, konqresdə izləyici kimi qatılan mütəxəssislər illik tələb olunan 48 kredit balının 16-sını toplaya bilərlər. Konqresdə iştirak etmək istəyən mütəxəssislər qeydiyyat üçün Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyətinin saytına və konqresin təşkilat komitəsinə müraciət edə bilərlər. Xatırladaq ki, 2009-cu ildən etibarən hər 2 ildən bir Bakı Ürək Günləri Beynəlxalq Konqresi təşkil edilir.
Hi, everybody. Welcome to Congenital Heart Academy. I'm Dr. Grace von Leeuwen from Sidra Medicine, Qatar, and I'm glad to give you a quick overview about us. The Congenital Heart Academy was founded by Dr. Gil Vernovsky from Children's National, Washington, D.C., and Dr. Sasha Gatti from Bambino Gesù in Italy. Dr. Sasha and myself are the co-chairs. We have the great support of more than 60 delegates from all around the world. Congenital Heart Academy is a web-based educational platform dedicated to worldwide healthcare providers involved with congenital heart diseases, sharing high-quality scientific knowledge and experience in a spirit of collaboration and union among the multidisciplinary team all around the world engaged in the care of patients with congenital or acquired heart defects from the fetal life through adulthood. We aim to reach every member of the multidisciplinary team worldwide, continuously delivering high-level education, ultimately helping to improve team collaboration and patient care. Since the pandemic began, the Congenital Heart Academy has put on more than 90 free webinars with 16,000 unique participants and 125 countries represented. More than 100 outstanding speakers have shared their knowledge and expertise. We've collaborated with several societies, including Pediatric Cardiac Intensive Care Society, Congenital Cardiac Anesthesia Society, the Society of Pediatric Cardiology Training Program Directors, Saudi Heart Association, and CENOC, Fetal Heart Gulf Group, and the Caspian Heart Foundation. 8 webinars have been in Italian and 2 in Spanish. In addition to the webinars, we have several series, including Dr. Robert Anderson's Morphological Series, where we discuss one cardiac disease each Friday, Dr. Norman Silverman's Correlation of Echo Images and Morphology once a month, Dr. Mary Cohen Amazing Echo Series, and Fetal Cardiology Series. Dr. Gil Vernovsky has his own series as well, debating all hot topics in pediatric cardiac intensive care and much more. In addition, Congenital Heart Academy is a collaborator of the 8th World Congress of Pediatric Cardiology and Cardiac Surgery, planning to showcase the content created for the 2023 World Congress in a virtual fashion. All content from Congenital Heart Academy is free and allows participants to join on the Zoom platform interacting with the faculty on the Q&A chat box, polls, etc., and is broadcasted live on YouTube. The Congenital Heart Academy YouTube channel keeps all talks free for watching later as well. Please follow us on social media and subscribe to our YouTube channel. Invite your team and join us on our future meetings. Thank you very much for this opportunity to share with you more about Congenital Heart Academy.
Değerli qonaqlar, değerli həmkarlarımız, kollegalarımız, değerli qonaqlarımız, xanımlar və cənablar. Hamınız xoş gəlmisiniz Bakı Ürək Günlərin Beynəlxalq Konqresinə. Bugünkü toplantı birlikte geçir Anadan Gəlmə Ürək Qusurluğun Akademiyasından birlikte və mövzumuz çox maraqlı və çox ciddi problemə aiddir. Ürəyin sol mədəciyin hipoplazik sindromu və bizim çox dəyərli spikerlərimiz var. 4 nəfər Dr. Robert Anderson, Dr. Vernovsky, Dr. Salvatore Agati and Dr. Grace von Leeuwen. Dear colleagues, dear guests, you are welcome to Baku Heart Days International Congress. Today our session devoted to a very serious problem for better understanding of hypoplastic left ventricular syndrome. Söz verilir hürmetli Doktor Elnur Gasanova. Birinci danışmak için.
Dear colleagues, I would like to take an opportunity and say thank you for Congenital Heart Academy member for the joint meetings. And I would like to introduce Dr. Robert Anderson with his topic morphology and definition, hypoplastic left heart syndrome. Please, doctor.
Discuss with you on behalf of the Congenital Heart Academy the morphologic background to what, justifiably, we can now think of as hypoplastic left heart syndrome. And if we're going to do that, we have to look at where the term itself originated from. And we go all the way back to the Stellar paper published by Noonan and Nadas, Boston Children's Hospital, in 1958. And in fact, they suggested that the term, the syndrome, was coined by Maurice Lev, the great cardiac pathologist. And what he was describing, according to them, was a group of anomalies unified because they had an obstructive lesion, either atresia or stenosis, on the left side of the heart. But in fact, they're not strictly true in making that suggestion because Lev did not coin the term syndrome. What he had described was hypoplasia of the aortic outflow tract complex. And if we look at his initial description, this was the one to which Noonan and Nadas were referring. It came from 1952. And at that time, he included cases with ventricular septal defect. But it's intriguing that subsequent to the study of Noonan and Nadas, Lev revisited the arrangement, and this time in his second publication, he excluded cases with deficient ventricular septation. And to me, this is the key to our current understanding of what we should and what we shouldn't call hypoplastic left heart syndrome. So let's look again at what Noonan and Nadas were talking about, because they grouped their cases on the basis of the clinical signs and symptoms. And some patients had ventricular septal defects. Indeed, some had atrioventricular septal defects. One of their patients had congenitally corrected transposition. It's intriguing that half of them, more than half, had what now I think we would diagnose simply as severe coarctation. But what they did was that they made groupings. And they noted that in these patients who presented in comparable fashion, some had mitral and aortic atresia, some had mitral atresia and aortic stenosis, others had mitral stenosis and aortic atresia, and then still others had combined mitral and aortic stenosis. As I say, at that time, they were including some patients who had only a ventricular septal defect in these settings. Now, we're looking for the genetic background of what we can call the hypoplastic left heart syndrome. And because of that, it is important that we be precise with the patients we're grouping together. We should not be comparing apples and oranges. And that is why I now think it is key to take note of the integrity of the ventricular septum. Because although the left ventricle unequivocally can be hypoplastic in the setting of a ventricular septal defect, we know that if the ventricular septum is intact, that means that whatever produced the malformation occurred subsequent to closure of the embryonic interventricular communication. And we also know that during development, that happens at around 8 weeks. So to me, the key point is that the integrity of the ventricular septum tells us that there has been an insult after 8 weeks of development. And that tells me that the features I'm going to be describing to you are acquired problems that have happened during fetal life. But it's also the case that, as Noonan and Nadis have described, there are several anatomic combinations. So there is marked phenotypic variability in what we can put together as belonging to the spectrum of lesions seen in the setting of hypoplastic left heart syndrome. And it is very much a spectrum. And I'm going to demonstrate that spectrum to you. So at the worst end, there is combined atresia of the mitral and aortic valves. And then we find that the mitral valve can be stenotic in combination with an atretic aorta, or both the mitral valve and the aortic valve can be stenotic. And then at the best end of the spectrum, we come across that entity that we can call the hypoplastic left heart complex. So let's look at these anatomic features that we find in the setting of what we can put together as the hypoplastic left heart syndrome. So as I say, at the worst end, we have atresia of the mitral valve. And that can be due either to absence of the atrioventricular connection or presence of an imperforate valve that is blocking the left atrioventricular junction. So this is what absence of the left atrioventricular connection looks like when we slice the heart in four-chamber fashion. There, between the floor of the left atrium and ventricular mass, we find fibroadipose tissue. At some stage, there has been a connection present, but the insult has happened sufficiently early that the embryo and the heart have modeled the situation that what we now see is absence of the atrioventricular connection, significantly with a slit-like left ventricle that lacks any fibroelastosis. The other variant giving this mitral atresia is what you see here in this lovely heart prepared by my good friend and colleague, Diane Spicer. We see that there is an imperforate valve that is guarding the left atrioventricular junction. In this instance, the left ventricle is a little more globular, but it is still tiny. Key point, it is lacking any fibroelastosis. These cases with mitral atresia go along with aortic atresia, and that is what I'm showing you here. So the flow from the heart comes through the pulmonary trunk. All the blood that is entering the systemic pathways is coming through the arterial duct, and then it's going in retrograde fashion into the aortic arch. And then the thread-like ascending aorta is no more than a conduit that is feeding the coronary arteries. And this thread-like aorta is what we find at the worst end of the spectrum in combination with mitral atresia. So if we move a little on in the spectrum of lesions, we find that the mitral valve can be stenotic. And when it is stenotic, it permits flow to run into the left ventricle. And it is that flow, I believe, which promotes the fibroelastotic lining in the left ventricle, which becomes globular. We see that in this explant from a patient undergoing cardiac transplantation, again prepared by Diane Spicer. And you see this time the mitral valve is stenotic, and that has permitted blood to flow into and out of the left ventricle, which has become more globular, a significant point, lined by this fibroelastotic layer. The right ventricle is apex forming, and this is another of the phenotypic features of the hearts we put together as belonging to the syndrome that we call left heart hypoplasia. So here then you see the patent but stenotic mitral valve in another heart with mitral stenosis, but this time in combination with aortic atresia, still in the setting of that thick-walled left ventricle with its fibroelastotic lining. This time, however, initially there must have been blood flowing through the aortic root, but with the progress of fetal life, the aortic root has become atretic, So now we see tri-radiating valvar sinuses, and the aorta is that little bit larger than it was in the combination of mitral atresia and aortic atresia. But then we can move on within the spectrum, and here we see aortic stenosis. Again, we have a thick-walled left ventricle with the fibroelastotic lining, and that tells us that the blood has been coming into and out of this ventricle through the patent but stenotic mitral valve. And now, because there is aortic stenosis, the aorta is that little bit larger still. And the flow into and out of that left ventricle is also important because it produces fistulous connections between the cavity of the left ventricle and the coronary arterial tree. So we only find these fistulous communications when there is mitral stenosis. And my late lamented very good friend Robert Freedom maintained that it was these fistulous communications in the setting of mitral stenosis that blighted the myocardium. We know, in fact, that microscopic communications between the cavity of the left ventricle and the coronary arteries are ubiquitous. This was shown by my other good friend and colleague, Willie O'Connor, who works at the University of Kentucky in Lexington. But it is when the communications are overt, they have this very bad prognostic feature. So you all know that should you find overt fistulous communications, that is bad news for the patient. So if we consider the phenotypic variability that we can see in the setting of the syndrome, which, as I say, is an acquired disease of fetal life, at the worst end, we have combined mitral and aortic atresia. Then as we move on in the spectrum, we see that in the setting of aortic atresia, the mitral valve can be stenotic rather than atretic. And then as we move on a little bit better, we have combined mitral and aortic stenosis. But the fibroelastosis here is still a very bad prognostic feature. But then at the best end of the spectrum, we get this combination of mitral and aortic stenosis that many call the hypoplastic left heart complex. And the essence of the so-called complex is that the aortic and mitral valves are miniaturized, but they are commensurate in size with the left ventricle. And that gives the surgeon the option of producing a functionally biventricular circulation. This is the type of heart we're talking about. This was diagnosed by the pathologist who made the original autopsy as hypoplastic left heart syndrome. And that is because the right ventricle is apex forming. But you see that in this heart, both valves are stenotic but relatively well formed. They are commensurate in size with the left ventricle itself being quite well formed. So here there was severe aortic coarctation. Had the case now been diagnosed during life, there might be the option in this setting for biventricular repair. And this is the best end of the spectrum we could put together as belonging to hypoplastic left heart syndrome. We've recently examined a large series of hearts diagnosed initially by pathologists as having the syndrome. And when we look at the series, about a third of them had combined mitral and aortic atresia. The majority had aortic atresia in combination with mitral stenosis, but then about a quarter at the better end of the spectrum with combined mitral and aortic stenosis. And in those 26 hearts, in 11 of them, we did consider it was justifiable to diagnose them as having what might be considered hypoplastic left heart complex. This is the account of our experience, and it gives you some idea of what is to be happened within the heterogeneity that we see in hypoplastic left heart syndrome, because I should emphasize, it is a combination of phenotypes. It is not like tetralogy, where you find a solitary phenotype which gives diagnosis. hypoplastic left heart syndrome is a combination of lesions that we can consider as representing an acquired disease of fetal life. They have to have certain things in common before we make the diagnosis of the syndrome. They must have essentially concordant atrioventricular and ventricular arterial connections. So there is no justification for including double outlet right ventricle as part of the syndrome, even though in the setting of double outlet right ventricle, we know the left ventricle can be hypoplastic. Equally, the left ventricle can be hypoplastic in the setting of ventricular septal defect or atrioventricular septal defect, but again for me, I would not put those cases as part of the syndrome. And that is important when we think of clues we might get from animal experiments as to the genetic background, because as yet, there are no animal models of hypoplastic left heart syndrome when it is considered an acquired disease of fetal life. So for you as clinicians, what are the significant surgical features? I should tell you that you don't need to put all your money into the autopsy diagnosis, because it is not possible for morphologists such as myself to tell you, when we look at the specimens, whether the left ventricle would have been capable of supporting the circulation. That is a decision that has to be made in the clinical arena. The best we can do is to provide you with guides as to what's going on, and we can tell you that the presence of fibroelastosis is a very bad prognostic feature. If you have combined aortic and mitral stenosis, if the left ventricle has that thick fibroelastotic lining, it's very unlikely that it will support the systemic circulation. Other bad prognostic features: intact atrial septum is bad news, as are those fistulous communications with the coronary arterial tree. And do not forget, in over half the cases, you will find aortic coarctation. So if I put everything together, hypoplastic left heart syndrome is a disease, an acquired disease of fetal life.
Thank you, Mr. Anderson, for your very interesting presentation. We will discuss all questions after all presentation. And now we are continuing our events, and our next presentation, Dr. Jill Wernovsky, with Physiology of Hypoplastic Left Heart Syndrome. Please, doctor. Hello, my name is Gil Wernovsky. I am a pediatric cardiologist and cardiac intensivist at the Children's National Hospital in Washington, D.C. in the United States of America. I'm very honored to participate in this wonderful symposium, and I will be talking for 15 minutes on single ventricle physiology and perioperative care. I have two goals related to this short presentation. The first is to emphasize accurate terminology, and the second is to emphasize the therapeutic target of systemic oxygen delivery. And although most of my examples will be from my experience with hypoplastic left heart syndrome, these principles apply to all forms of functionally univentricular heart. This is an external view taken in the operating room of a neonate with hypoplastic left heart syndrome. You can see the very small diminutive ascending aorta. And I like to explain the physiology in a way of thinking that you are inside the right ventricle, and as the ventricle ejects, you have a number of choices. And the first is that you have two areas for distribution. And this is an example of a highway here in the United States. And for the purposes of this discussion, we will say that down to our left is the low resistance circulation to the lungs. And over here on our right is the high resistance circulation to the body. In many ways, as the ventricle ejects, the blood must go uphill to provide oxygen delivery to the tissues. And that has to happen through an unobstructed patent arterial duct. I must apologize for the abbreviations for those of you who are not native English speakers. But in general, the majority of the blood flow ejected from the single ventricle will take the path of least resistance and flow downhill preferentially into the pulmonary vascular bed. Where these neonates get into particular trouble suddenly is if there is a problem with outflow into either one of those vascular beds. I like to call this a multi-distribution circulation. And as I'll show you in another diagram later, it is a better term than single ventricle physiology. The fundamental problem we see in newborns with a delayed diagnosis is shock due to constriction of the ductus arteriosus. So I've tried to get away from the term single ventricle physiology and instead talk about a multi-distribution circulation. And when this occurs, there's complete mixing of pulmonary and systemic venous return. The aortic and pulmonary artery oxygen saturations are equal, and the univentricular output is distributed to one of three areas: high resistance systemic vascular bed and the low resistance pulmonary vascular bed. But also one must remember that the third area of distribution can be due to atrioventricular valve regurgitation with the passage of blood from the ventricle to the atrium. Let's talk a little bit about the transitional circulation in a neonate with a functionally univentricular heart. For the purposes of these diagrams, I will have flow to the body over here on your left, flow to the lungs here on your right, and this is a single ventricle in the fetus with hypoplastic left heart syndrome. And in that fetus, there is low systemic vascular resistance, particularly due to the placenta, and high pulmonary vascular resistance due to the fluid-filled lungs. Therefore, the majority of the output from the systemic right ventricle proceeds to the body and to the right atrium, whereas a minority of blood flow goes to the pulmonary vasculature. Recent data would suggest from MRI spectroscopy that fetal oxygen saturation in this scenario is about 65%. Now, imagine the baby is born, the umbilical cord is clamped, and the baby starts to spontaneously breathe. Immediately, there is a fall in the pulmonary vascular resistance shown here on the right, an increase in systemic vascular resistance shown here on the left, increased flow to the lungs on the right, decreased flow on the left, and an oxygen saturation that goes up to 80%. And with further fall in pulmonary vascular resistance, there's less flow to the body, more flow to the lungs as oxygen saturations go up. So let's look at that again. You can focus your attention over here on the body, where you're the fetus. Now you're the newborn. Now you're 2 or 3 days old. Saturations go up. Systemic blood flow tends to go down. Where these babies, as I said, get into difficulty is when the ductus closes and the baby will develop low cardiac output, acidosis, and shock. I do want to point out, however, that not all patients with an oxygen saturation in the 90s are necessarily sick. If the systemic right ventricle can keep up with both systemic and pulmonary blood flow, these babies can actually do quite well as long as the ductus arteriosus is open. Now let's look at the other side, tricuspid atresia, where one has a single left ventricle. The same physiology occurs in the systemic vascular resistance and pulmonary vascular resistance. The difference being here is that the oxygen saturations are 65%. And the difference here is that the restriction to flow may be to the lungs rather than to the body. So with an open ductus, the patient presents with high oxygen saturations and typically normal cardiac output. However, as the ductus closes, the baby presents with hypoxemia. So the fundamental difference here is that babies with low pulmonary blood flow are going to present with hypoxemia, but no heart failure. And that is typically seen in ductal-dependent pulmonary blood flow. And babies with ductal-dependent systemic blood flow will present with heart failure or maybe even shock with high oxygen saturations. In general, it's very uncommon to have both hypoxemia and shock in the same patient. And I want to talk a little bit about the QP to QS ratio and balancing the circulation. We've used these terms for quite some time. They assume a number of things like ventricular function, pulmonary vein saturation, and I think that these terms should be eliminated. They are simplistic, they're outdated, and they're simply wrong. Unfortunately, I created a lot of this a number of decades ago when we talked about how it was important in these babies to target an oxygen saturation of 75 to 80% and a ratio of the two pulmonary blood flows to 1, QP to QS ratio of 1. It makes a number of assumptions. And the other wrong assumption is that ventricular output is fixed without variation. So these are sort of old strategies to target an oxygen saturation or a QP to QS ratio from an old book that's now 30 years old that I participated in. And I'm happy to say that we've moved much beyond that simplistic evaluation of single ventricle. If any of you have had the opportunity to see the section I've written with Jim Tweddle and others on single ventricle, we're very proud of it in Anderson's Pediatric Cardiology. My experience, again, comes from both Boston Children's and Children's Hospital of Philadelphia, primarily, where I've cared for somewhere around 1,500 children with hypoplastic left heart syndrome. And there was a period of time, as you can see here, where roughly, this is in Philadelphia, roughly 2 patients per week were having a stage 1 Norwood operation for a number of years. Over time, the mortality decreased for standard risk patients is now in the 10%, 7% range, has gone down over time. And that's due to a number of both technical as well as conceptual ideas. The first is that early on, we felt that the majority of the management was necessarily focused on the pulmonary vascular resistance. We learned that after surgery, the shunt is the biggest resistor to pulmonary blood flow, not the pulmonary vascular resistance, and began to target the systemic vascular resistance. And then finally got to the point where we tried to move these patients along as rapidly as we would move an arterial switch patient, for example. So in my view now, these babies require frequent observation, but try to minimize the tweaking of the ventilator just to get the perfect blood gas or going up and down on the inotropes. Our general approach, the first goal of our ICU team is to set up the surgery at the lowest possible risk. So how do we do that? How do we think about the management of that? And for the longest time, we talked about a ratio of the pulmonary to systemic blood flow, so-called QP to QS. And we targeted and taught this a lot, and I think it was too simplistic. This is the formula that we use to calculate the ratio of pulmonary blood flow to systemic blood flow. As we talked about before, because the aortic and pulmonary artery saturations are equal in this disease, you can first simplify that equation by using aortic saturation from your pulse oximeter in the numerator and the denominator. We know that the lungs generally are normal, so one can assume 95. And if we make an assumption that the mixed venous oxygen saturation is roughly 25% below the aortic saturation, a very simple bedside calculation means that you could put 25 over 95 minus the pulse oximeter and get the ratio of the two. And therefore, our goal oxygen saturation, and we've talked about this for a long time, should be about 80%. However, that is not specific nor sensitive to good cardiac output. As Mencken said, there's always a well-known solution to every human problem that is neat and plausible, but unfortunately also wrong. There's too many assumptions that we make in this curve. So the trouble with the term balanced circulation is that it's not specific. So here's an example of a baby that has an oxygen saturation of 60% and a venous saturation in the superior caval vein of 25%. So the arterial venous difference is 35, same in the lungs. So this is a baby that has a, quote, balanced circulation. The ratio is 1, but unfortunately is very, very sick and may die and is anaerobic and profoundly hypoxemic. The other problem with a goal oxygen saturation, such as 80%, is here's a baby whose calculations are 80%, but has a superior caval vein saturation of 35%. That baby's in low output. So if we don't know all of these numbers, the saturations in the lungs and in the veins, we can't use and make these assumptions. And as I said before, babies that have a high oxygen saturation may be quite healthy, but may be sick. And it's not, in my view, important to immediately start therapy when the oxygen saturations are high. As Bill Rashkin once told me, the only thing you have to do stat is to think. So is the baby sick? Is oxygen delivery low? Are we dealing with this situation or dealing with this situation? And both can happen in the same patient. So the one take home that I'd like to give you at this point is if a baby starts to have a high oxygen saturation and becomes sick, the most important thing is to check the arterial duct and the IV that's delivering the prostaglandin. So finally, the take-home point is that balancing the circulation and a high oxygen saturation needs to be changed. We should be maximizing oxygen delivery, minimizing morbidity, and not targeting a particular PO2. Pulmonary overcirculation may matter in the context of lung disease, but pulmonary undercirculation always matters, and systemic undercirculation always matters. Here is a very brief description of where the blood goes in a multi-distribution circulation. So you could see that the ventricular output, which is determined by afterload, contractility, preload, and heart rate, is distributed to the systemic blood flow, is distributed to the pulmonary vascular bed, and may be distributed to the regurgitant fraction. All of these must be assessed in your patient with a single ventricle, not just the ratio of those two blood circulations. So, general terms, and I'll wrap up with this. It's helpful to mimic the concepts of the fetal circulation, keep the systemic vascular resistance low, the pulmonary vascular resistance high, a widely patent ductus, and minimize additional therapies, ventilators, inotropes, et cetera, as we're moving forward. So the most important goal for the ICU team is to set up the surgery at the lowest possible risk. Finally, the best way to limit pulmonary blood flow is with a tube of Gore-Tex. I believe these kids, or pulmonary artery bands, I believe these children should have to prompt surgery because the physiology just gets worse each day. And perioperative care is exactly the same way. It's not a balance. It's maximizing systemic oxygen delivery. I know my time is running short, so I'm going to just show you one evaluation of, we've shown this slide, of how to assess the patient in low cardiac output and hypoxemia. So here's our patient with signs of low cardiac output. The first step in that situation should be an echocardiogram. If there's pericardial fluid, drain it. If there's bad function, support it. If there's valve regurgitation, use afterload reduction or surgery, arch obstruction, or a systemic steal. You must have an echocardiogram to evaluate for those situations. And finally, if there is hypoxemia, we know that that could be due to lung disease, low output, or decreased pulmonary blood flow. A chest x-ray, an echocardiogram, and a catheterization is the way to go. Cardiovascular physiology with a functional univentricular heart is the complete mixing, the multi-distribution circulation, and mimicking the fetal physiologic principles. Unobstructed systemic blood flow, unobstructed systemic and pulmonary venous return, and limited pulmonary blood flow. Once again, thank you very much for the honor of participating in your symposium. Thank you, Mr. Wirnowski, for a very interesting presentation. Actually, I got a lot of interesting for me. Thanks again. And now I would like my colleague, dear Dr. Fuat Abdullayev, to introduce our next speakers, please.
Okay, our next invited guest, Dr. Salvatore Agati. He will present a lecture concerning first stage surgical approach in hypoplastic left heart syndrome. You are welcome.
Good morning. I would like to thank you very much, Professor Azanov, for the invitation, this special meeting of Baku Art Days. We really appreciate the opportunity to share with all of you this experience about hypoplastic left heart syndrome that is one of the most challenging disease still remaining in the field of congenital heart disease. I really appreciate this paper from Professor Haas, who's demonstrated clearly that it's not a real recent disease, but it's a very long story. And this child from Detmold clearly demonstrate again that you can see a CT scan and autoptic evaluation with clear small left ventricle and a very small aorta in a child of 6,500 years ago. And again, if we look to what is the actual strategy or what is the actual diagnostic tool we use to decide about the surgical strategy, here we have a fantastic schematic approach to left ventricle and left hypoplastic ventricle, and we see here that probably the most worst disease is still considered the mitral aortic atresia, and of course we are doing also this strategy for patients with hypoplastic left heart complex, and of course we have also different type of anatomopathologic features that must be approached for single ventricle palliation. But if we want to look very fast, very suddenly to what we can do for this type of patient, I think that in most of the center of around the world, this is a very well known, and I would like only to drive your attention and your next 15 minutes about the treatment of patients that have aortic flow obstruction. And again, if we look in 2021, what is the overall management around the world about for this type of disease, we can say that mostly of the center is now focusing on fetal diagnosis, and this is a very diffuse all around the world, but very few centers are looking for about intervention during fetal life. But still, we have a very huge diffusion of neonatal management about this population of patients. And again, the experience from Boston about the left ventricle recruitment, that is still something very debated in our surgical field. But focusing on the first stage palliation, I would like to stress the idea that it's very simple, it's very well known that the goal of this first stage is focused on mimic the fetal single ventricle circulation. And this is very easy, and sometimes we know this very well, but it's not easy to make it happen on clinical practice. And this is make clear to have two unobstructed way. One is the one from the ventricle to the descending aorta, but the other one that is very important is the one from pulmonary veins to the ventricle. And one of the point that is still on focusing about the research is the source for pulmonary blood flow. We know that we can use several strategies, bellotaxi shunt, PDA stenting, RV2PA conduit, or native pulmonary stenosis in the case of different anatomopathologic diagnosis. And here we want to, of course, remember this year we'll miss Professor Norwood, and this is the most important part of his surgical strategy.
We call this amalgamation of the aortic root with the pulmonary root, and you can see here very easy, and I'm sure most of you knows about this technique with the interrupted suture between aorta and pulmonary. And again, one of the most famous shape we have in cardiac surgery is the homograft used for the aortic arch reconstruction, and this is coming mostly from pulmonary side of donors. And again, this is the final results of fantastic reconstruction proposed by Professor Norwood. And here you can see very well how this amalgamation is central part of initial results also in post-operative care. And here again you have the modification by Professor Shunji Sano, who start to use left BT shunt from the right ventricle to the left pulmonary artery, or in some case from right pulmonary artery. And he started to use, of course, PTFE conduit from 5 to 6 millimeters. And it's what I really like to share with you, that this is our way we do the reconstruction. Generally, we use continuous cerebral perfusion at 6 ml per kilogram, and cerebral needs monitoring, continuous monitoring. But in recent cases, we start to use also coronary artery continuous perfusion, so we are able to do beating heart reconstruction of the completely aortic arch and coarctation. We are very lucky in this field because for the first time in the congenital heart field, we are able to present results from a very huge randomized trial that is a single ventricle. And here is clear with its real improvements in the use of right to ventricle pulmonary connection, trying to show you here that the most important point is focused on the interstage period. But if we look at 3 years and 5 years results, this difference going to be very small, and reduce the curves like to be the same. And again, if we look to another important endpoint, that is the Fontan procedure, the results of proportion without Fontan, it's be the same between both approach, the BT shunt or the Sano shunt. So again, this year was a very strange year, but we are very happy because during the pandemic period with our Congenital Heart Academy, we were able to update some information about the disease. And this was the case of a meeting that we made with Professor Del Nido, who presented the improvements about the use of conduit in the reconstruction proposed by Professor Sano, focusing on two principal points, that is the proximal stenosis and the pulmonary regurgitation. And again, he presented the experience coming after the introduction in clinical practice of the Dunking method, which was introduced by Professor Jim Tweddle. Here you can see a real easy schematic approach. In the first traditional method, there was no reinforced Gore-Tex tube graft sutured directly to the right ventricle, rather than in the ring reinforced graft, two pieces of the conduit are introduced to the hole in the right ventricle and fixed only with a simple suture, a round suture, without doing a real anastomosis of the conduit. And again, he presented the preliminary result about the Duncan conduit, and here you can see that the Duncan conduit clearly demonstrate an improvements when compared with traditional conduit, and this make real sense to extend this type of procedure for people who are interested in Sano technique. And again, The other point was presented by Professor Del Nido was the improvements in R2PA conduit, and he proposed a composite graft with both the ring, the Gore-Tex graft and the valved femoral vein conduit that you can see here in the schematic view, but you can see also here in this video presented at the Congenital Heart Academy. You see the valved conduit. A metallic stent is fixed to the outflow part of the conduit in correspondence of the valve in order to doesn't make the losing the continence of the valve, and again with interrupted suture. Then this conduit is anastomosed in end-to-end fashion to the ringed graft in order to create a real new conduit with a valved continuity. So I think that this is a real up-to-date that we were able to share with you in 2020, thanking to Congenital Heart Academy. Now it's time to share what is our approach in congenital heart case with this very complex disease like hypoplastic, and our center has a hybrid suite, dedicated hybrid suite when this hybrid procedure is a treatment of choice for our patient, and most of the procedure has been done in day 1 or day 2. Now we are going to present, of course, our results, and when we check out to this, we were able to confirm that no inotropes was used before surgery, and in the last 18 cases, we were able to extubate patient the first 4 hours at least, and no chest drain, no pacemaker wires, and peritoneal dialysis was used. And really learning from this technique, we were able to approach this patient directly in the ICU. We call this rapid ICU bilateral bending in the cases of very bad low cardiac output. And here, thanking to Gabriella Ricciardi, I would like to share with you the real step-by-step approach we use in our center. After full sternotomy, we open a very small square pericardium just over the vessel, and we had a 6-0 stay in the left aspect of the pulmonary trunk, and we generally use in all the case a 3mm Gore-Tex shunt to bending to stabilize the left pulmonary branch. This is something that we learned from the experience, and this approach, we learn also that the positioning of left pulmonary artery bending of 3mm doesn't make a very big hemodynamic impact, and we decide, we make a real improvements when you understand to use the right pulmonary bending as a real flow chart for the decision about the final saturation. And here you can see that in mostly of the case we use a 3.5 millimeters bending, and the rule of 5 minutes. When you bend the patient like this, you have suddenly a low saturation, and after the crisis, the suddenly reduction of flow, you have a reestablish of the normal saturation. And again, another important message that I would like to share with you is that the PDA must be full covered at the time of the stenting. The PGA is generally stopped at the start of the procedure, and the stent placement is putting only when the patient is completely stable and without inotrope and without hemodynamic instability. In our experience, we don't have a real stent migration, and 2 patients require additional stent placement. And here we have the real experience. In 10 years, we accumulated about 78 cases with hypoplastic left heart complex and syndrome, and of course 70% of these have complete from completion. I would like to share with you and show you what is something dedicated to our center. That is that before discharge we used to do percutaneous RASC in mostly of the cases, and if the patient require an additional procedure during the first 6 weeks of life, we generally proceed for elective Norwood. And again, don't forget the option for transplant in patients with aortic atresia and sinusoid. What do we learn? We learn that coarctation is very frequent in this population of patients, and that sign of 3, we call the 3 sign on the echo. So the coarctation incision in the aortic arch at the PDA insertion can be one of the cause of reverse coarctation. So in this case, we proceed with pulmonary artery blending plus prostaglandin infusion for 6 weeks before we proceed for Norwood operation. And again, we have experience with the standing of the interatrial septum, but we learned that a part of a very difficult procedure is if the patient require again some adjustment for hybrid procedure, is better to proceed for a elective Norwood rather than to remain in such of an unstable hemodynamic situation. So what is the ideal sequence? I think that Norwood and Sano clearly demonstrate similar results in long-term observation and in randomized patients. So we can say that we are mostly close to the reality. And I think that hybrid procedure is something that can be considered a sort of consensus option about patients with a low birth weight or some syndromic disease. But I think also that this approach can be helpful in patients where you need time to decide, like bridge to decision or heart transplant candidates. And again, the final consideration that I think is very important, that every center must decide according to the experience, trying to have a personalized strategy for each patient according to what is the best results you achieved, or what is the best diagnostic tool you prefer to apply for your patient. Again, I hope that really fulfill all the requirements of this presentation, and thanks a lot to Professor Hasanov again, and see you soon on Congenital Heart Academy.
Thank you very much, Dr. Salvatore, for your very elegant presentation and your experience. So next, our speaker, Dr. Grace Van Leuven, who will present post ICU care stay in these patients. You are welcome, Dr. Leuven.
Hi, everybody. My name is Grace Van Leeuwen. I work for Sidra Medicine in Doha, Qatar, and I'm very happy to participate on this hypoplastic left heart syndrome session with those amazing speakers at the Baku Heart Days 2021. So today I'm going to cover the most important topics of the post-op care of the patients after the first stage of palliation of a hypoplastic heart syndrome. We are going to talk mainly about Norwood and Norwood-Sano procedure, but we are going to have a quick overview about the post-op care of the hybrids as well. It's important to remember that the good post-op period starts much before the patient enters on the ICU. This patient needs a good fetal diagnosis and to have planned all the interventions after birth or something before birth if it's needed. So this patient needs to have a good pre-op management and a fully understanding of his physiology, as Gilvernovsky just talked to us about. We need to choose the right surgical technique, as Sasha talked to us about as well. And we need to find the good anesthetic strategy and the best way to do the cardiopulmonary bypass everything to make this patient to have the best possible outcome. I recommend all of you to take a look on this guideline that was published last year. I use this guideline a couple of times during this presentation, but it covers since the fetal life until the end of all palliations for these patients, and it's a very comprehensive guideline. I think it's worth taking a look. Well, what changes on our patient from the patient that we sent to the OR to the patient who is coming back to the ICU? The vascular resistance are not the same. Maybe our myocardium has some dysfunction because of the cross clamp and because of the disease itself, and we can have increased capillary leak because of the bypass. So we need to keep this in mind when we are going to treat these patients after Norwood or Norwood Sano. So when these patients arrive in the ICU, we need to have a very good comprehensive handover. So we need to know which patient we are taking care of. So if this patient had any risk factor for a most complicated post-op care, we need to know how the surgery went, if there was any issues with the anesthesia, if there was any unexpected findings, how was the final outcome of the surgical procedure. And this is one example of a handover sheet, a template. So in this paper that was published on Pediatric Critical Care Medicine 2011, just showed that standardized protocol for handover is very important for our patients on the ICU. So if you don't have it already on your ICU, a standardized handover, please start to do it. It's very important. It can really change the outcome of your patient. Well, we need to have a good monitorization for these patients when they arrive on the ICU, and after that on all of his post-op period, the normal monitorization with ECG, arterial saturation, ETCO2, temperature. And something that we need to remember is that the arterial line is very important. We need to get a good sample for labs, and we need to have as well a good understanding of the systolic and the diastolic pressures of these patients, and the invasive is the best way to do that because we can monitor this in a continuous way. Remembering that if our patients go to classic Norwood with a BT shunt, that they can have a runoff and low diastolic pressure that sometimes needs intervention. On our central line, central venous line, we need to have a good reading as well to monitor the preload, either if it's CVP or the atrial pressure, and we can have samples of the mixed venous saturation that is very important parameter for the post-op care. We can use NIRS monitorization as well. That is a way to continuously monitor the mixed venous saturation. It's a good surrogate of the mixed venous saturation. So the mixed venous is very important. Gilbernovsky already talked to us about it, but just for you to know that in the first 48 hours of the post-op care, monitoring SVO2 can improve the survival, can diminish the complications, and can improve the neurodevelopment of this status of these patients on the long term. So the ideal SVO2 that we are aiming is 25% less than arterial saturation, or in general numbers, 50 to 60%. This publication from 2012 shows us that having a better SVO2 on the first 48 hours of the post-op leads to less complications and less mortality, less arrest, and less needs of ECMO in these patients. And this is one paper showing that the NIRS monitorization is important for these patients post-Norwood, and having a good NIRS was linked to a better survival of these patients. So we are hoping that our post-op goes without too many issues, but there are a lot of things that can happen during this post-op, and we are going to talk briefly about them. So the most common complication that we have on the post-op of a Norwood or Norwood Sano is low cardiac output syndrome. We know all the signs and symptoms, but we need to remember that the low SVO2 is an early marker, and we should monitor this very closely. So we need to know the cause to be able to treat it. This is something that is important to remember, that of course low cardiac output syndrome can be caused for poor ventricular function, but there's a lot of other things that can cause that. We need to remember sometimes we forget. Sometimes we think that, okay, the ventricular function is good, so this is not low cardiac output syndrome. But we can have all other causes for low cardiac output syndrome that we need to make the diagnosis and to treat accordingly. So how to evaluate? By the monitorization that we already have, by the clinical symptoms of our patient, the physical exam, and echocardiography and ECG are important for that as well. We need to give this patient a general treatment. So delayed sternum closure is a good strategy when you have low cardiac output syndrome. If your patient had already the chest closed, you should ask your surgeon to open it again. You should sedate and paralyze and normalize the temperature of this patient to try to decrease the oxygen consumption. Maybe you should transfuse some packed red blood cells to try to increase the oxygen delivery. And a good strategy is to decrease the systemic vascular resistance using vasodilators. So this is one paper, one of a lot that we have, showing that Mirinon is a good drug for these patients on the post-op care, and probably they should be used as a default to all of these patients, at least in the first 48 hours. So we need to make the diagnosis of the cause, because we need to give the specific treatment for that as well. We can have all of these issues. We can have tamponade, and we need to explore the chest. We can have AV valve regurgitation. We can try to treat this medically with afterload reduction. We can have arrhythmias, and we can have arch obstruction that I'm going to show you an example right now. And to remember that if our patient is not improving, ECMO should be started before the patient is too sick, and especially before the patient arrests. This is going to improve the outcome of your patient if you start ECMO early. So this is one example from my previous program in Brazil. So you can see this patient has an important obstruction on the aorta where you have the arrow. And this patient was doing unwell on a post-Norwood period. And then we intervened. So we stented this area, and the patient developed very well after that. So we can have other issues with these patients. Another example is excessive cyanosis. So when we have excessive cyanosis after Norwood or Norwood-Sanu, in my mind, I always use the same mental diagram as this publication is showing. Or it can be because the lungs are not good. So the blood that comes through the left atrium from the lungs are already desaturated. So you can have any issue with the lungs. The worst one is AV malformation, but usually it's just a pleural effusion or a ET tube that is malpositioned, and this is easiest to fix. You can have decrease systemic venous saturation. We need to remember that is a mixed circulation, so all the blood from the pulmonary venous return and the systemic venous return is going to mix in the atrial level and then go to the right ventricle, and it's going to be distributed to both circulation, systemic and pulmonary circulation. So if the blood arising from the venous side is too much desaturated, this is going to cause cyanosis. And the two causes of this blood is too much desaturated, or we have an increased oxygen consumption, or we have a decreased oxygen delivery, and this we can fix. As we already talked about, increasing, correcting the low cardiac output syndrome, or maybe correcting the anemia, decreasing the oxygen consumption, as we did on low cardiac output syndrome. So these can help you to decrease this excessive cyanosis. And sometimes you have inadequate pulmonary blood flow because the systemic resistance is too low, or because the pulmonary resistance is too high. But usually when you have a decreased pulmonary blood flow, there's something wrong with your shunt, with your BTT, or with your Sanu conduit. We can have obstruction, or they can be too small, the size was chosen and was not adequate, or you can have some issues with the pulmonary arteries, some obstruction, some kink, and all of this can lead to excessive cyanosis. You need to make the precise diagnosis to be able to treat it. So Of course, when you have excessive cyanosis, you are going to give your patient the general management as well, transfuse red blood cells if needed, paralyze, sedate, make him with a good corporal temperature, try to get him out of the low card output syndrome, and then you're going to treat the lungs if the lungs are the problem. And if everything fails, consider ECMO. Don't delay too much ECMO for these patients. And if the cause is because there's any obstruction on the pulmonary arteries or on the shunts, you need to send this patient as soon as he's a little bit more stable to the cath lab to solve the issue, or sometimes even to the OR again. So this some other issues that we didn't cover, just to talk briefly about it. So using anticoagulation for these patients after Norwood or Norwood Sano is mandatory. So we anticoagulate these patients with heparin. If these patients had acute kidney injury that is not responding to diuretics, we should consider dialysis as soon as possible. These patients, if the cardiac output is good, they can be fed and they should be fed. And again, reinforcing the importance of these patients going on ECMO early before they arrest. By statistic, around 10% of the patients after Norwood Sano or Norwood Classic would require ECMO. So we need to, when we do one surgery like that, we need to know that maybe we are going to use ECMO and be ready for that. There's another nice publication that I think all of you should read as well, is the guideline of the PALS, of the Pediatric Advanced Life Support, that was published in 2020, a new publication. So it's a very nice paper actually, and they talk about the chain of survival, and they start talking about that you need to recognize signs of impairment of your patient to try to prevent your patient to arrest. So the treatment of the cardiac arrest in pediatrics should start much before the patient arrest. And here they talk a little bit about the post-op of Norwood and Norwood Sano, and they talk about what we already talked about monitoring the venous saturation with NIRS with a venous set directly, to give vasodilators or Murinon to these patients, to use ECMO early if needed, and if we have a shunt obstruction, to treat it rapidly and consider ECMO as well if needed. I'm going to give only this few words about the post-op of hybrid, that I think is a little bit more a stable procedure than Norwood. And this patient have no chest tubes, no pacing wires. You don't expect a complicated post-op care, only if you send these patients to hybrid because they were too sick to be able to do a Norwood or a Norwood Sano, then it's another story. But if you send your patient electively for the hybrid procedure, you're not expecting any big complications. Of course, everything can happen. This patient can tamponade, can have arrhythmias, can have low cardiac output, but this is not the usual behavior. So it's very rare that we need epi or something like that. Usually we keep these patients on Murinon. We try to extubate early. Some centers extubate these patients even on the OR. So that's what I had for you guys. I'm very happy to be here. Thank you very much. And I'm happy to answer any question now on the discussion, or you can access me by email anytime. Thank you.
Thank you, dear Dr. Grace, for a great presentation. Thanks a lot. Now we have to begin our discussion, but as I know, we have not any question, and that's why I would like to finalize our meeting and want to say thank you for accepting our invitation for all Congenital Heart Academy family or Congenital Heart Academy members. I know that it's just beginning. It's our first joint meeting, and I'm sure that our cooperation will continue and bring an excellent result. If you want to say something, please.
Thanks. Congratulations for this appointment. I think that we have to change a bit our way to look to the science, and the way we are looking to the academy is something that we really think is a part of the future. The contents of we saw the contents of your meeting, and it was a real update about both adult and acquired and congenital heart disease. So congratulations. We are here, whatever we can support or we can help, we would like to be there. Thanks a lot. To compliments to all the organization.
Thank you. Thank you, and see you later in our next meetings. Thanks. Dr. Grace, maybe you want to say something? Tamam, teşekkür edirik hər birinizə. Sizin bu joint meeting başa çatdı. İnşallah gələn il ümid edirik ki, online yox, artıq konferans zalında böyük bir mitinglərimizi keçirdəcəyik. Təşəkkür edirik, sağ olun.
Ümummilli lider Heydər Əliyevin anadan olmasının 98-ci il dönümünə həsr olunmuş Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi işə başlayıb. Dünyada mövcud olan COVID-19 pandemiyası səbəbindən Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyəti tərəfindən keçirilən konqres onlayn formatda baş tutub. 2 gün davam edəcək konqresin keçirilməsində əsas məqsəd Azərbaycanda kardiologiyanın və ürək-damar cərrahiyyəsinin inkişafına töhfə vermək, əcnəbi mütəxəssislərlə birgə fikir mübadiləsi aparmaq və tibb elminin bu sahədəki son yeniliklərini müzakirə etməkdir. 20-yə yaxın ölkədən kardioloq və kardiocərrahın mühazirəçi kimi iştirak etdiyi Bakı Ürək Günləri 7-ci Beynəlxalq Konqresində ürək-damar xəstəlikləri və onların müalicəsindəki ən aktual məsələlər, o cümlədən COVID-19 pandemiyasının ürək xəstəliklərinə təsiri və dünyanın aparıcı ölkələrində müalicəsinin təşkili müzakirə edilir. Kardiologiya və ürək-damar cərrahiyyəsi mütəxəssislərinin, həmçinin bu sahə ilə əlaqədar olan digər mütəxəssislərin konqresə izləyici kimi qatılmalarının tam sərbəst olduğunu deyən Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyətinin sədri Professor Kamran Musayev Dünya Uşaq Kardiologiyası və Ürək Cərrahiyyəsi Cəmiyyəti ilə əməkdaşlıq çərçivəsində anadan gəlmə ürək qüsurlarının konqresdə ayrıca bir sessiyada müzakirə ediləcəyini bildirib.
Bu səfər də onlayn şəraitdə keçirilməsinə baxmayaraq biz Konjenital Ürək Akademiyası ilə, yəni anadan gəlmə ürək qüsurlarının Ürək Akademiyası ilə beynəlxalq təşkilat kimi biz onlarla əməkdaşlığa getdik və sabahki sessiyalarımızdan biri məhz onlarla birlikdə ortaq toplantı olacaq. Və bununla da mən elə hesab edirəm ki, sadəcə böyüklərin, yetişkinlərin ürək-damar xəstəlikləri deyil, uşaqlarda anadan gəlmə ürək qüsurlarının da diaqnostikasında və müalicəsindəki aktual problemləri biz dünyanın aparıcı mütəxəssisləri ilə müzakirə etmə imkanı əldə edəcəyik.
Kamran Musayev onu da bildirib ki, Azərbaycan Səhiyyə Nazirliyinin Elmi Tibbi Şurasının iclasında Bakı Ürək Günləri 7-ci Beynəlxalq Konqresi davamlı tibbi təhsil verən tədbir kimi tanınıb və konqresə 16 kredit balı verilib. Bu o deməkdir ki, konqresdə izləyici kimi qatılan mütəxəssislər illik tələb olunan 48 kredit balının 16-sını toplaya bilərlər. Konqresdə iştirak etmək istəyən mütəxəssislər qeydiyyat üçün Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyətinin saytına və konqresin təşkilat komitəsinə müraciət edə bilərlər. Xatırladaq ki, 2009-cu ildən etibarən hər 2 ildən bir Bakı Ürək Günləri Beynəlxalq Konqresi təşkil edilir.
Beləliklə, konferansımızın son günü sona çatdı. Konferans zamanı izləyicilərimiz gördüyünüz kimi kardiologiyanın və ürək cərrahiyyəsinin ən aktual mövzuları müzakirə olundu. Anadan gəlmə ürək qüsurlarından tutmuş, böyüklərdə ürək əməliyyatlarına, ürək xəstəliklərinə və pandemiya dövrü nə edəcəyimizə qədər mövzuları müzakirə elədik. Hamınıza təşəkkür edirik və son sözü Professor Kamran Musayevə vermək istəyərdik.
Mən də 7-ci Bakı Ürək Günləri Beynəlxalq Konqresinin son sessiyasından sonra son sözləri demək üçün sizinlə bərabərik. Koronavirus pandemiyasının bütün yaratdığı texniki çətinliklərə baxmayaraq, Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyəti olaraq Bakı Ürək Günləri Konqresi ənənəmizi davam etdirməyə çalışdıq və inanıram ki, onlayn şəraitdə də olsa uğurlu bir konqresi başa vurmaq üzrəyik. Bunu bizim 2 gündə ortalama 500 nəfərin üzərində olan izləyici sayımız da bunun göstəricilərindən biridir ki, biz uğurlu bir konqres təşkil edə bildik və yenə inanıram ki, müxtəlif xarici ölkələrdən bizə çıxışçı olaraq qatılan çıxışçılarımızın təqdim etdiyi məlumatlar, aparılan diskussiyalar bütün hamımız üçün, bütün həmkarlarımız üçün çox faydalı olmuşdur. Hamımız üçün biliklərimizin bir yenilənməsi olmuşdur. Çoxumuz üçün yeni məlumatlar əldə etmişik. Mən buna görə fürsətdən istifadə edib hər şeydən əvvəl dəyərli bizim izləyicilərimizə, dinləyicilərimizə minnətdarlığımı bildirirəm ki, onlayn şəraitdə də olsa bu 2 gündə yüzlərlə dəyərli həmkarımız bizim konqresimizi izlədi və çıxışçılarımıza minnətdarlığımı bildirmək istəyirəm ki, həqiqətən öz sahələrində dünya səviyyəli, dünyada tanınan, bilinən aparıcı mütəxəssislər öz biliklərini bizimlə paylaşdılar və bunun üçün də mən həm öz adımdan, həm sizin adınızdan minnətdarlığımı bildirmək istəyirəm. 7-ci Bakı Ürək Günlərində sizin də artıq 2 gündür bildiyiniz kimi biz Konjenital Ürək Akademiyası ilə əməkdaşlıq etmişdik. Elə biraz əvvəl sizin də izlədiyiniz ortaq sessiyamızı həyata keçirdik. Dəyərli həmkarım Elnur Həsənovun da qeyd etdiyi kimi bizim bu Konjenital Ürək Akademiyası ilə ilk əməkdaşlığımız idi. Azərbaycan Ürək və Damar Cərrahiyyəsi Cəmiyyəti olaraq. Amma mən inanıram ki, bundan sonra da bu akademiya ilə bizim əməkdaşlığımız davam edəcək və daha bundan sonra da daha yaxşı ortaq layihələri biz birlikdə həyata keçirə biləcəyik və fürsətdən istifadə edib mən də öz adımdan Konjenital Ürək Akademiyasının üzvlərinə, rəhbərliyinə öz minnətdarlığımı bildirmək istəyirəm. Təbii ki, bu cür konqreslərin, toplantılarının keçirilməsində mütləq sponsor dəstəyi hər zaman çox vacibdir. Bizim bu konqresimizdə də çox dəyərli sponsorlarımız var idi. Mən onlara da burada adlarını çəkib təşəkkürümü bildirmək istəyirəm. Dəyərli Kırka firmasına və Azərmet şirkətinə öz adımdan və Azərbaycan Ürək Damar Cərrahiyyəsi Cəmiyyətinin adından minnətdarlığımı bildirmək istəyirəm ki, onların dəyəri dəstəkləri ilə biz 7-ci Bakı Ürək Günləri Beynəlxalq Konqresimizi həyata keçirmiş olduq. Və təbii bu texniki şəraiti bizə yaradan və onlayn konqresimizin həyata keçirilməsində bilavasitə rolu olan Medikal Media şirkətinə mən öz minnətdarlığımı bildirirəm. Hansı ki, hal-hazırda biz onların studiyasından sizinlə görüşə bilirik və bütün ölkəmiz üçün də, bizim üçün də yenilik olan bu cür texniki şəraiti yaradan və bizə təqdim edən Medikal Media şirkətinə də mən öz minnətdarlığımı bildirmək istəyirəm. Və icazənizlə bu təşəkkür hissəsini xüsusilə bizi hal-hazırda mən görürəm izləyən xarici qonaqlarımız və çıxışçılarımızın bir hissəsi olduğu üçün ingiliscədə qısaca mən təşəkkürümü bildirim icazənizlə. I want to thank again all contributors and all speakers our Baku Heart Days Congress. I would like to emphasize that your tremendous contribution is very, very valuable for us because we know that you are each of you are a leader of your fields, and it's great pleasure for us, for Azerbaijani colleagues, that we hear your voice, your lectures, and as I said, it's very valuable for us. I once again to thanks our speakers, our contributors, and I believe that our cooperation will continue. Our speakers and another international organization. As an Azerbaijan Society for Cardiovascular Surgery, we want to develop our bilateral relations with international organizations and international speakers, and I believe that our next meetings will be more efficient and more valuable for different our online meetings, and I hope that our next meeting will be classical congress, and our international contributions also will be better than online congress. I once again thanks to all contributors and especially all speakers, our dear friends. Thanks again. Ve değerli izləyicilərimiz, Azərbaycan Ürək Damar Cərrahiyyəsi Cəmiyyəti fəaliyyətə başladığı 2004-cü ildən etibarən özünün əsas məqsədi olan Azərbaycanlı həmkarlarımızın bilik və bacarıqlarının yenilənməsində, təkmilləşdirməsində öz rolunu oynamağa davam edir. Eyni zamanda xalqımızın, insanlarımızın tibbi maarifləndirilməsində, xüsusilə ürək-damar xəstəlikləri barəsində fəaliyyətinə davam edir. Həmkarlarımızın elmi praktik səviyyəsinin yüksəldilməsində ən vacib yollardan biri məhz bu cür konqreslərin, konfransların, toplantıların təşkil olunmasıdır. Hansı ki, Azərbaycan Ürək Damar Cərrahiyyəsi fəaliyyətə başladığı 2004-cü ildən etibarən bu günə qədər onlarla lokal, yəni yerli konfrans, toplantı, seminarlar təşkil edir və hal-hazırda sonlandırmaq üzrə olduğumuz beynəlxalq konqresin isə artıq 7-cisini biz təşkil edirik. Bizim cəmiyyətimizin digər fəaliyyət istiqamətlərindən biri də jurnalımızın təsis olunması idi. Bu bizim ilk gündən xəyalımız idi və nəhayət yaxın illərdə biz bu xəyalımızı gerçəkləşdirdik və Azərbaycan Ürək Damar Cərrahiyyəsi jurnalını nəşr edə bildik. Bir sevincimi də sizinlə bölüşmək istəyirəm ki, artıq 2021-ci ildə yenə Covid pandemiyasının yaratdığı bütün mənfi təsirlərə baxmayaraq biz jurnalımızı yeniləyə bildik, daha yüksək səviyyəli və beynəlxalq standartlara uyğun hala gətirdik. Bunun üçün də jurnalımızda ciddi yenilənmələr, yeniliklər baş verdi. Onu sizinlə bölüşmək istəyirəm. Belə ki, bizim jurnalımızın dili artıq demək olar ki, tamamilə ingilis dilinə çevrilmiş vəziyyətdədir. Hal-hazırda bütün texniki tələblər bir jurnalın, tibbi jurnalın nəşr olunması üçün bütün beynəlxalq tələblərə uyğun hala gətirilmişdir. Həm jurnalın çap variantı bu hala gətirilmişdir. Jurnalla əlaqədar məqalələrin qəbul olunması, məqalələrin dəyərləndirilməsi hamısı beynəlxalq standartlara uyğun təşkil olunmuşdur. Jurnalın çap variantının texniki variantı dediyim kimi beynəlxalq tələblərə uyğun hala gətirilmişdir və eyni zamanda jurnalın saytını da biz yenilədik. Hal-hazırda siz ekranda bu saytı görürsünüz və elə fürsətdən istifadə edərək bizi izləyən bütün həmkarlarımızdan məqalə göndərmələrini, həm yerli, həm xarici həmkarlarımızdan məqalə göndərmələrini xahiş edirik. Tamamilə onlayn şəraitdə məqalələrinizi göndərə bilərsiniz. Dəyərləndirmələr ən az 2 xarici hakim tərəfindən olacaq və onların nəticəsinə görə məqalələrin çap olunub olunmayacağına biz qərar verəcəyik və bizim hədəfimiz beynəlxalq elmi tibbi jurnal bazalarında təmsil olunmaqdır. Hal-hazırda bir xəbəri də sizinlə paylaşmaq istəyirəm. Xüsusilə Azərbaycanlı həmkarlarımız üçün onu deyə bilərəm ki, jurnalımız Azərbaycan Respublikasının prezidenti yanında Ali Attestasiya Komissiyasının qəbul etdiyi jurnallar siyahısına daxil olmuşdur. Bu bizim üçün düşünürəm ki, Azərbaycan Ürək-Damar Cərrahiyyəsi Cəmiyyəti və Azərbaycanlı ürək-damar cərrahları olaraq çox böyük uğurdur. Amma biraz əvvəl də qeyd etdiyim kimi biz bununla kifayətlənmirik. Bizim hədəfimiz Azərbaycan Ürək-Damar Cərrahiyəsi jurnalını beynəlxalq bazalarda da təmsil olunmasına nail olmaqda. Bu yöndə də bizim komandamızla birlikdə çox ciddi olaraq çalışırıq. Sizin də dəstəyinizə bizim ehtiyacımız var. Elmi səviyyəsi yüksək məqalələrinizi, xüsusilə ürək-damar xəstəlikləri ilə əlaqədar olan mütəxəssislərdən biz gözləyirik. Yəni bunlar kardiologiya barəsində, ürək-damar cərrahiyyəsi barəsində, anadan gəlmə ürək qüsurları ilə əlaqədar pediatrlarımız, pediatrik kardioloqlarımız, pediatrik kardiocərrahlarımız, ürək-damar cərrahiyyəsi və ürək-damar reanimasiyası ilə əlaqədar olaraq, tibb bacılığı ilə əlaqədar olaraq bu sahələrlə əlaqədar olan məqalələrinizi gözləyirik və inanıram ki, sizin də dəstəyinizlə biz önümüzdəki illərdə jurnalımızın məhz hamımızın arzuladığı o beynəlxalq bazalarda da təmsil olunmağına nail olacaq. Bununla da Ramil həkim, əgər sizin də bir sözünüz yoxdursa, mən bir daha bu konqresin həyata keçirilməsində əməyi keçən başda Azərbaycan Ürək-Damar Cərrahiyyəsi Cəmiyyətində olan təşkilat komitəsinin üzvləri və medikal media şirkətinin çalışanları olmaq şərtlə bütün əməyi keçən hər kəsə öz minnətdarlığımı bildirirəm və hamınıza sağlam həyat və uğurlar arzulayıram. Çox sağ olun, gələn görüşlərədək.